Um, Komal, you can introduce Professor Sheikh.
Good afternoon, everybody. Welcome back to INRC Spine Surgery webinar course. In this session, we are very happy and extremely fortunate to have Professor Rajshekhar with us, Professor and Head of Christian Medical College, Vellore, India. He will be starting the session with his talk on tuberculosis of cervical spine. Welcome back to INRC Spine Surgery webinar course.
So should I go ahead and start the share screen, Naren?
Yes, please. Yes, sir. Over to you, sir. Professor and Head of Christian Medical College, Vellore, India. He'll be starting the session with his talk on tuberculosis of cervical spine. Welcome back to INRC Spine Surgery webinar course.
Should I go ahead and start the share screen, Naren?
Please, thanks. I think you.
Yes, over to you, sir.
Yes, sir.
There is some audio feedback I'm getting.
Okay. All right.
Tuberculosis of cervical spine. Welcome back to INRC Spine Surgery webinar course.
Okay. Can you hear me? Should I go ahead?
Go ahead.
Okay. Good afternoon, everyone. I guess it's morning for some and later in the evening for others. But I would like to begin by thanking Komal and Naren for organizing this great webinar and inviting me to participate in it. So I'll be speaking about craniovertebral junction and subaxial cervical spine tuberculosis. Cervical spine and CV junction tuberculosis is not that common of a disease as compared to thoracolumbar tuberculosis. So why am I talking about it? The reason is that this is one disease that if picked up quickly and treated appropriately will give excellent results and almost a complete, functional patient at the end of the therapy. So if you look at the duration of symptoms, patients with CV junction tuberculosis tend to have shorter duration of symptoms. Those with subaxial tuberculosis may have symptoms even up to a year or longer. Now, one of the classical features of both CV junction and subaxial tuberculosis is neck pain with severe tenderness, which is present in over 90% of the patients. It's understandable that these patients present often with spastic quadriparesis or with radiculopathy. Another point to note is, although this is tuberculosis, these patients may not have symptoms of tuberculosis elsewhere in the body. In other words, they may not have any fever. They may not have systemic tuberculosis like lymph nodes or evidence of pulmonary tuberculosis. So typically this is seen in about 15–20% of patients. So looking for such features elsewhere may not yield a lot of evidence of tuberculosis. Now, CV junction and cervical spine TB is one of those diseases of the spine which can almost definitely be diagnosed on the basis of a plain radiograph in an appropriate clinical setting. And when I say an appropriate clinical setting, I am also, of course, talking about in countries where tuberculosis is endemic, such as in India. The disease is almost purely ventral. So it involves the ventral vertebral elements. And usually there is an enlarged prevertebral shadow, as is shown in these radiographs. These patients had CV junction tuberculosis. So you can see the atlantoaxial dislocation, a large prevertebral shadow here. And in these radiographs of patients with subaxial cervical spine tuberculosis, you see the same findings, a large prevertebral shadow, along with destroyed vertebral bodies and the loss of the disc space. There is also evidence of instability in all these four radiographs. Now, when you go on to the MRI findings reflects reflect those seen on the plain radiograph. Again, note that the disease is almost entirely ventral. There will be prevertebral or paravertebral abscesses in some, as you can see here, which track up and down beyond the area that is involved. In some patients with severe cord compression, you can see changes in the cord, like this increased signal intensity. There's a syrinx in this patient. Of course, bony destruction and enhancement of the granulation tissue are the other features that can be noted on an MRI. In the cervicovertebral junction tuberculosis, besides an MRI, a CT scan is almost essential so that you can plan your surgery well. For example, in these two patients with CV junction tuberculosis, you can see not only the atlantoaxial dislocation, but also disease involving the C2 body with erosion and destruction of the body. And in this axial CT image, you can see the position of the odontoid and the extensive destruction of the lateral mass of the atlas. This is an unusual case where the disease is restricted almost entirely to the lower part of the clivus with no atlantoaxial dislocation. Here is another patient with the CV junction tuberculosis showing the prevertebral shadow and the extensive granulation tissue in that region, which is enhancing with contrast. So at the end of the imaging, this is the type of diagnosis that we could arrive at in our series of CV junction tuberculosis and subaxial TB. We had patients with irreducible atlantoaxial dislocation, reducible atlantoaxial dislocation, basilar invagination or impression, and just destruction of the C2 body without any instability. As far as subaxial TB is concerned, the C5-6 region is maximally involved and followed by C3-4. Remember that although I said at the beginning that you can almost make a definite diagnosis of tuberculosis on the basis of plain X-ray findings, do not forget that there are other diseases that mimic tuberculosis. The foremost amongst them is a pyogenic osteomyelitis of the subaxial cervical spine, not so often the CV junction, but the subaxial cervical spine. It's very difficult to differentiate tuberculosis and pyogenic osteomyelitis, although there are supposedly some pointers that favor one over the other. Nevertheless, I would be hesitant to, definitely say this is tuberculosis or pyogenic. Similarly, sometimes neoplastic disease, other less common granulomatous diseases such as brucellosis, fungal, and finally, very, very infrequently, hydatid disease. Therefore, when you begin the management of a patient suspected to have subaxial or CV junction tuberculosis, you should attempt to get a definitive diagnosis. So in these the next two slides, what I'm going to share with you are the principles of management. Now, the specifics can vary. How you go about it can be a point of discussion, debate, but nevertheless, the principles remain the same. So you begin with ascertaining the diagnosis using either a CT-guided or an ultrasound-guided biopsy. Sometimes you have a large retropharyngeal abscess, you aspirate the pus and send it for culture for the acid-fast bacilli, or you may resort to an open biopsy and culture. And when there is compression of the neural elements, both clinically and radiologically, we need to decompress these neural elements. But again, this is a matter of debate. Some surgeons believe that this is not necessary in every patient. We'll come to that shortly. And when you do the decompression, most surgery will be from in front because, as I said, the disease is ventral in most patients. You may have to resort to some posterior surgery for stabilization for CV junction tuberculosis, but the decompression part of it typically is a ventral surgery. Then you come to the realignment of the spine if there is instability using traction to begin with, skull traction, and or intraoperative reduction. The final principles of management are stabilization of the spine, either with external immobilization in a halo or a cervical collar, or a surgical immobilization using instrumentation, or without instrumentation, as I tend to do for the subaxial spine, in an attempt to make sure that the patient can return to work as soon as possible. But I want to emphasize the fact that the treatment ultimately is medical therapy. So surgery does not cure this disease. We need to treat these patients with anti-tuberculous therapy for prolonged periods. Now, whether it's going to be 12 months or 18 months is again a matter of debate and personal choice, but definitely for several months, more than 12 months is what I would recommend, and 18 months is what is generally followed by Indian neurosurgeons. So let me begin with sharing some examples of our experience with subaxial cervical spine tuberculosis. As far back as 1962 and in 1969 by Dr. Thuli et al., they suggested that some of these patients can be treated with conservative therapy. In other words, there's no need to operate on these patients. If these patients had no myelopathy, they only presented with neck pain, you just give them a cervical orthosis, like we did for this patient in the upper panel. This is at presentation. As you can see, destruction of the bodies and the disc space between them with a large prevertebral shadow. And we treated this patient conservatively with just a collar and anti-tuberculous therapy. This patient did not have myelopathy. And a year later, this is the result. The prevertebral shadow is gone. The bodies have fused, and there's a reasonably good alignment of the cervical spine. This patient reported no further symptoms at this point in time. I must emphasize that I am a little wary of pursuing conservative therapy if there is a bony compression. So I believe that as long as the cord is not being compressed by a bony element, I would still think of conservative therapy, as in this patient illustrated in the panel below. This was a 62-year-old male who presented to us only with neck pain, again a large prevertebral shadow, C3 body destroyed, but no instability. As you can see, he's got extensive osteophytes in front, and I guess at the back too, and probably even an OPLL. This patient was reluctant to undergo surgery. So we just aspirated this, confirmed that this was tuberculosis, put him on a collar, gave him anti-tuberculous therapy, but told him that he needed to report back to us at the end of 3 months or earlier if he had progression of symptoms. So he did come back to us at 3 months, absolutely asymptomatic, and this is the result on the X-ray. The prevertebral shadow has regressed almost completely. The body still shows some erosion, but this is what worried us when he presented to us, the MRI findings showing this kind of a compression of the cord. So typically we wouldn't have offered this patient conservative therapy, but the patient chose, saying that I have no other symptoms except neck pain. And ultimately at the end of 3 months, you can see that the cord is completely free of any compression, although he has a congenital or a canal stenosis due to probably OPLL. This patient, of course, requires further follow-up, but this is just to illustrate the spectrum of disease where conservative therapy could be tried. Now, when we do resort to surgery, there's nothing really specific about it, except that, like I said, it's anterior surgery, so we go in from front, take out the pus and the diseased bone and disc material. Now, when you go beyond that, beyond the body into the epidural space, besides draining the pus, be conservative with removal of the granulation tissue. You would like to see the dural pulsations, but don't try to scrape off all the granulation tissue from the dura, and take all precautions to ensure that you do not open into the dura, because you don't want to convert an epidural disease into meningitis. I, like I said, prefer to do just uninstrumented corpectomy and with an iliac or a fibular bone graft. And the reasons I do that is due to my bias and training. I've had good results, as I will share with you shortly. Lower cost, no foreign body, less morbidity, less bone removed, and fewer segments that are immobilized. But Instrumentation is safe in tuberculosis, as has been shown by several studies that I have quoted here, which again, I will share with you shortly. So these are some of the radiographs of our patients. You start with traction, as I said, so you get some kind of a reduction here. And this is one of our patients, immediate post-op. We did a corpectomy at one level, a C5 corpectomy, I believe, and a year later, a good bony fusion. Patient is asymptomatic with good neurological result. Another patient, kyphotic spine, preoperative, typical TB spine, and at 6 months, you see the graft in place, no instrumentation, pretty good alignment. And then this patient also went on to have a good result. Here is another patient with more than one body involved, C3, C4, and part of C5. If you were to put a plate, you would have had to go to C2 and probably C6. We managed without any instrumentation, and at the end of 2 years, you see a solid bony fusion at that level with, again, a reasonably good alignment. So we published our series several years ago in the British Journal of Neurosurgery. This, I think, was a series of about 13 or 14 patients. Some of them presented in neuric grade 5. That means they were bedridden. A follow-up at about 2 years, a mean neuric grade was 1. And here is the table showing the pre and the post-operative grade. All patients below this blue line have improved. So everybody has improved. Patients in grade 5, 1 improved to grade 2 and 1 improved to grade 4. Patient in grade 4 became grade 0. So you see these patients have a very good outcome on long-term follow-up. Again, examples of some of these patients, severe kyphosis, uninstrumented corpectomy. I agree, there is a little bit of a kyphosis, but after 1 year, this does not progress. Believe me, this remains like this and the patient do well. Again, another one of our recent patients, MRI before and after uninstrumented surgery, showing you the decompression of the card. These are examples of outcomes with instrumentation. Dr. Ramani, one of the pioneering spine surgeon, neurosurgeons in our country, published this paper way back in 2005 using an expandable cage and another cage here. And this is a more recent paper from China, where the use of plates and screws are shown, again, with a very good outcome. I just want to finish by saying, as far as subaxial spine TB is concerned, is that sometimes people who do instrumentation tend to do a 360 surgery, front and back, but I haven't had to resort to that if you do a good ventral decompression and fusion. So I'll quickly move on to CV junction tuberculosis. I don't have too much time, but I want to just familiarize you with the life source staging. Stage 1, no bony erosion or instability. Stage 2, bony erosion but no instability. And stage 3 with bony erosion with instability. This is just a case report that we published several years ago showing basilar impression. So as far as management of stage 1 is concerned, you need to obtain a diagnosis. Again, similar principles to that of subaxial TB. We don't need to do neural decompression because there is no compression. You just immobilize the patient, antituberculous therapy. But remember, you need to follow up these patients closely, both clinically and radiologically, because you can have delayed instability. As far as stages 2 and 3 is concerned, again, go through the diagnosis, reduction with cervical traction, especially for stage 3 disease, decompression, which may involve an odontoidectomy if there is no reduction intraoperatively. Again, do not violate the dura. Immobilization intraoperatively with occipitocervical or C1, C2 fusion, hard cervical collar for 3 months, and do not forget the antituberculous therapy. So these are our publications on CV junction tuberculosis, one in Journal of Neurosurgery and one in BJNS, just to show you that in the JNS paper, that these patients presented in 4 neuric grade quite often, 4, 5, 4, 5. But you look at their outcome grade, it's 0, 0, 2. And this is at the end of about 2 years, 4 years, and so on. So again, just to illustrate the fact that these patients have a very good outcome if treated appropriately. Some images from that those papers. This was when we were doing, these loops for the posterior fusion, but more recently, we do these transarticular screws, and an excellent result for this patient with atlantoaxial dislocation. But there was this a little bit of a provocative article from Dr. Gupta's group in Chandigarh, who asked this question: is surgery necessary at all? So they managed 16 patients, just diagnosed with biopsy, immobilized everybody after a traction in a halo vest for 3 months, antituberculous therapy, and then showed results like this, and their patients had an excellent outcome. My only concern is this issue of delayed instability. So there is this perspective that you really do not need to operate on them. And there is another paper from All India Institute in 2008 where they had a more nuanced approach where they didn't suggest that everybody undergo conservative therapy, but they suggested that this may be appropriate for patients in their grades 1 and 2 conservative therapy, and only operated on a very small percentage of patients, again, front and back and transoral with posterior fusion. But note that after a good response to treatment, 6 patients went on to develop an atlantoaxial dislocation and needed posterior fixation. And this is what I mentioned earlier, that you need to follow up these patients because you can get delayed instability. Finally, I just want to share with you some data from our center about drug resistance. So we looked at patients from 2000 to 2013, and we noted that in the later half of our series, we were noticing drug resistance in quite a substantial proportion of our patients. So this was not there in the earlier cohort of our patients, but this is a problem that you need to be aware of, and this may be the reason why your surgery can fail and the patients have a poor outcome. So I just want to conclude by saying that suspect this disease, especially in the right clinical setting and the practice setting, but establish a diagnosis. Consider conservative therapy in selected cases, but if you are doing that, have a close follow-up. Surgery, of course, should be again in selected cases, but I just want you to remember that do not give up on a patient with suspected TB, because even patients who are bedridden can ultimately have an excellent outcome with no symptoms. Of course, remember the need for antituberculous therapy, and when things don't go right, consider drug resistance. Thank you. Yes, Komal, I'm ready for questions.
Thank you very much, Professor Rajshekhar. I'm just unmuting the microphones, Dr.
Sure.
Prasad. Okay. While I try to unmute Dr. Prasad, I will ask Dr. Patki to ask your questions. Dr. Patki, do you want to ask Professor Rajshekhar the question? Okay. So I will ask it on behalf of Dr. Patki. He's asking, can medical line of treatment be started only on radiological findings without biopsy?
I would hesitate to do that.
Sorry. Yes.
There is an echo. Okay.
Yep, please.
Yeah, so I would hesitate to do that, but I understand that sometimes we have no other choice. I just also want to caution everyone that even if you take a biopsy, ultrasound guided or CT guided, you may not get a definitive diagnosis. The pathologist may just tell you, I'm just seeing some inflammation, and the culture may not grow anything. Remember, the culture in such patients is only positive in about 20 to 30% of cases. So you may not see acid-fast bacilli either in your aspirate or on culture. Anyway, culture takes a long time. Even on expert TB, your culture positivity is not high. It's only 20 to 30%. So yes, in selected cases where you don't have a definitive diagnosis, you could go ahead with empiric therapy, but please do not forget to ask the patient to come back for follow-up as often as possible, maybe at the end of even 1 month. If the patient lives close by, why not?
That's brilliant. Thank you very much. Dr. Abhishek Patil has a question. Dr. Patil, do you want to ask?
Yes, sir. Good afternoon.
Good afternoon.
So I just, radiologically, what are the key points that we see here to differentiate tuberculous affection from metastasis? And yes, even I had the same question as the first one. That is biopsy absolutely mandatory in each and every case?
Yeah. So as far as metastasis is concerned, that typically metastasis does not involve the disc material or the disc space. It's restricted to the body, and you'll just see a collapse of the body. And the collapse also is more central. I mean, the central part of the body is involved. The tuberculous disease is more adjacent to the disc space. See, but these are all theoretical. So I've seen several patients with tuberculosis in whom the disc space is not involved. So again, the same answer that I gave to the first the question. I agree that sometimes you're forced to do empiric therapy without a biopsy, but try and obtain a diagnosis. You'll be surprised that occasionally you may get a staph osteomyelitis, staph aureus osteomyelitis, or sometimes even gram-negative. I've seen gram-negative osteomyelitis in a few patients. So, you never know. So try and do a biopsy or aspirate as far as possible.
That's great. There's a question from Dr. Galgano. I'll just put him on the mic just a second.
Hi, how are you?
Yeah,
Hey.
Great, Mike.
Hi, so the question I have is, I may have missed it. I had to step out for a moment before. What kind of anterior strut are you using, and how are you keeping their neck immobilized after the ventral reconstruction to allow for a bony fusion to take place?
Yeah. So sorry, I didn't share that. Yeah. So I am typically using iliac crest. I prefer iliac crest for 1 or 2 levels, but for a 3 level, I use a fibula graft. And I make mortises, as I was taught by Dick Saunders in Dartmouth long ago. And the mortises are great in keeping the graft in place. So once you have got a good fix in the operating room, virtually they don't ever slip out. And I just use a hard cervical Philadelphia collar for about 3 months. Mobilize them. Initially, I was very worried about mobilizing these patients immediately after surgery, so I used to keep them to bed for about 2 to 3 weeks. But now I'm more confident, and I let them get out of bed within a week.
Sure.
It works.
Have you ever had any struts spit out dorsally into the epidural space?
So I use the same technique for spondylotic myelopathy, of which I've done about 450 with uninstrumented corpectomies. And in those patients, I've had 1 in the first 10 patients. 1 patient had going back, but I've had about 6 or 7 coming out in front, but all in the first 50 patients. In the next 400 patients, maybe 1 or 2, but never going back. So it does happen.
That's excellent.
It does kick out occasionally. So yeah, but rare.
There's a question from Dr. Shyam. Dr. Shyam, do you want to go ahead, please?
Yes, sir. Good evening, Professor.
Good evening.
If there is only a single level spondylodiscitis, and I think if there is only a single column or a 2 column disease, should I go ahead and put a cage or something, or should I just decompress it and leave it like that, sir?
So what about the patient's symptoms? Does the patient have features of cord compression or myelopathy?
Yes, sir. Cord compression features are there, but
Yes.
But it is involving only a single column or 2 column disease. Then what should be the line of?
If there is no instability that is apparent, then I would just leave a small. If there is a place for a small graft, I would just leave a graft and use a collar. Yeah. So if there is no apparent instability, you can get away with it. Yes.
Actually, I had a similar case like this, and I put a peak cage, sir. Then it went for total dislodgement, and it actually sink in completely in the vertebrae below, sir. Then I had to put a streptomycin. After starting streptomycin, actually it started to get stabilized, but then I didn't remove the peak cage, which was actually collapsing completely into the vertebral body. Is that fine, sir? Or
I would tend to use an autograft as far as possible, and if not, an allograft, but autograft works best. Because one of the things that you notice with TB spine is that the fusion, bony fusion, is excellent. Means rarely will you have a pseudarthrosis. Means I've never seen one. So the inflammatory process, just make sure that the bony fusion is solid. So try and use an autograft as far as possible. I know it's another incision, but still worth it in the long run.
thank you very much.
Hello.
Komal Prasad, do you want to make any comments, please?
No, Professor has covered the entire spectrum in the brief time possible. And he has rightly pointed out the conservative approach which he has propagating from his experience, and that's the best strategy, is to be as conservative as possible. Sometimes what we notice, Professor, is there are two kinds of material what we get. One is when it is extremely granular matters, and one's which is sort of pyogenic and liquidy. Like, should our approach differ when we are operating based on the consistency of what we see?
That's a very good question. The problem, Komal, is to try and recognize this consistency on the MRI. And let me tell you, I've been fooled many times. When I thought I'll see pus, I've just seen granulation and the other way around. So you only discover this when you operate. I would still be, it means, of course, if it is pus, I would try to irrigate and get it all out. But if it's granulation tissue and densely adherent, I just want to see the pulsations of the dura. I'll leave a carpet of granulation on the dura. I mean, as long as the bony elements and the disc materials, the hard parts are out, you've done your work, you've done your job. So you don't have to worry, and the anti-tuberculosis therapy will take care of the rest.
Yes. And if you
Can
can
I ask a question?
Sure, Dr. Gupta, go ahead.
Dr. Rajshekhar, is there any
Hello.
change in the strategy when you are operating on 2 levels for a pediatric surgery patient, pediatric age group patient?
No, I didn't have time to show you, but our series have both pediatric and adult patients, and I use the same strategy. Actually, I would think that it's good to not put an instrument in a child in a growing spine as far as possible, and it works in children too.
Yeah. Thank you, sir. Thank you, sir.
Thank you.
And your duration, if you can stress again, sir, this you said 18 months is what you practice, AKT.
That's right. That's right. I know that's well, there's a lot of debate about it. There is a 12-month regime that's being promoted, but I think 18 months is what I would stick with right now.
Even we practice the same. And how long is the intensive phase, sir?
Intensive phase is 3 months, and 2 drugs, INH and rifampicin, typically for the other 15 months.
Thank you. Thank you, sir.
So so I answer the questions on the chat now.
Please, if that's okay, Professor,
Yeah,
that would be fantastic.
I'll do that.
Thank you very
I'll do
much.
that. Thank you again.
Thank you very much, Professor Rajshekhar.
Sure.
It now gives me pleasure and privilege to introduce Mr. Nicholas Zarakis. He's a consultant neurosurgeon at Department of Neurosurgery at Stoke-on-Trent Hospital, and also is the fellowship director for spine service in the Midlands region. Mr. Zarakis, very welcome. Can I please ask you to share your presentation, and greatly look forward to your talk on the most important and the commonest pathology that we see, radiculopathy, cervical radiculopathy.
Thank you very much. I hope that you can hear me okay. I will share my screen now. I'm Mr. Zarakis. I'm a consultant neurosurgeon in Stoke-on-Trent. I hope that you can see now the presentation.
Yes, we can. Yes, thank you.
So with regards to my disclosures, I have no actual or potential conflict with this presentation. And yes, starting with the definition of the radiculopathy, it is a disease of the spinal nerve root. The Latin word is radix, and the Greek word, which is pathos, means disease. And treating a patient, managing a patient means, first of all, we have to have the correct diagnosis. So I will start the management with a diagnosis, differential diagnosis, and after that we'll move to the different methods of treatment, including the conservative and the surgical methods. The diagnosis is probably made in the vast majority of the patients by the history. So a good patient, historian patient, and also a good doctor can pick up the specific symptoms, the pain, which is in the distribution of nerve. Obviously, the pain, which is in the radicular distribution, the arm is called brachyalgia, associated with paresthesia, the pins-and-needle sensation, and may or may not be associated with neck pain. In our examination, we can see the neurological deficits might be associated with some sensory changes, some motor deficit, weakness. The reflexes of the relevant muscles are involved, and in this particular case, they are decreased. I still say that we are talking about the radiculopathy, not the myelopathic signs. And also, we can reproduce the pain with specific tests, such as the Sperling's test. The Sperling's test is the equivalent of the straight leg raising test, the Lasek sign in the lumbar spine. So with regards to the distribution of the pain, obviously, one of the main routes is the C5 route going down to the shoulder. Other routes, the C6 going down to the lateral forearm, the thumb and the index finger. The C7 goes down to the middle finger, the C8 to the little finger, and the T1 goes to the medial aspect of the forearm. The weakness is involving the relevant myotomes, the C5, the deltoid, C6, the biceps, C7, the triceps, and the C8, the fingers. The relevant reflexes obviously are involved in the muscles involved. The differential diagnosis is quite important, and we have to exclude the pathologies which have very similar manifestations, such as the peripheral nerve entrapment, median nerve, carpal tunnel syndrome, cubital tunnel syndrome, brachial plexus pathologies, including plexopathies, including tumors, benign or even malignant, thoracic outlet syndrome, herpes zoster, and musculoskeletal conditions, particularly with regards to shoulder diseases. And it is quite common to see patients have what we call a double crush syndrome, having also pathologies from the shoulder or other joints, and also picture of radiculopathy. We have to remember these are elderly patients who might have more than one diseases. This is what we would like to see to most of our patients, a disc protrusion, either in the foramen or a posterolateral disc protrusion. Again, I'm saying I'm not talking about a disc compression of the spinal cord. Compression of the nerve causes the relevant symptoms to show before. And the MRI scan, it is the most important test in our attempt to identify what is the cause of the symptoms of the patient. You can see here the sagittal and the axial T2 imaging where the nerve is compressed at the foramen. And this is a picture because sometimes we don't have the typical, the simple soft disc, but we might have an osteophyte formation which compresses the nerve. And the osteophytes can be seen even on simple X-rays. We can see here the narrowing of the foramen compared to the other foraminae. This is an oblique view. It's quite nice to see the foraminae there. We see how narrow is this foramen. Of course, the X-ray is not the best test to start with, and sometimes it might give us some false positive findings, but it is also useful as a preoperative check. A very important test to do if we have question about foraminal stenosis is the CT scan, because it can show very nicely the osteophytes involving the relevant nerve root, and it can help a lot with regards to the decision how to do the operation. The pressure could be from the front osteophyte, could be the compression from the back. So depending on the area of the compression, we can make plans with regards to further management. Neurophysiological tests, many surgeons don't use them at all. I have to say that myself, I'm not very convinced about the usefulness of those tests, but we do use them when we want to diagnose between acute and chronic denervation changes. A good neurophysiologist, particularly if they use the needle test, the EMGs, can give us the difference between the two denervation changes. And obviously this has a value as a prognostic feature with regards to the recovery of the patient, the possible improvement even after an operation. But also it can help us with a differential diagnosis, particularly if we have a question about the peripheral nerves, or in case we have multiple level pathologies, it might pinpoint where the main pathology is. And the second part of the management is the treatment. In all pathologies, we can consider the conservative treatment, and it is quite important to keep that in mind, bear that in mind, because the cervical radiculopathy has a generally benign natural history, has a favorable natural history. Obviously, if the conservative treatment does work, we can proceed to more invasive pain relief procedures, including injections. And the last resort is always surgery, either the anterior or posterior route, as we'll see later on. And as we saw before in the very nice presentation about the tuberculosis. Again, the whole presentation about the radiculopathy, so if the patient has any red flag signs and symptoms that suggest that we have to act urgently, it is completely different philosophy for diagnosis and also for treatment. As we said before, the natural history is generally beneficial. It is favorable for this condition, and we have to always consider that, giving medications to our patients, mostly for pain management, follow an intense physiotherapy program. Sometimes we can suggest immobilization of the neck in the form of a collar. Some people find beneficial the collar, particularly in the nighttime when the muscle tone is decreased. They find some benefit by using a soft collar in the nighttime. No hard evidence about that. I rarely suggest immobilization myself in my practice. And the physiotherapists can try traction, and if everything of this conservative treatment fails, we can consider injections. As we said before, the natural history is beneficial, and this is known even from old studies, even from the 60s. They have started doing long-term studies which show that the vast majority of the patients, 70+%, they get better without an operation. So we have to always consider the possibility of conservative treatment. And other long-term studies in the 70s that go run down to 1996, they have also shown the same. So the non-operative treatment is always an option. And in this article, they had 26 patients, small series, but in the 1 year follow-up, 24 of them had a favorable outcome. Only one patient operated. We have to be very careful when we see those studies, because this is a very, very short period of time for a follow-up. And as we'll see later, this condition might deteriorate in the future. So 1 year is not enough as a follow-up to tell us how beneficial is a form of treatment. Medication can use according to the NICE guidelines, oral analgesics, simple ones like paracetamol, codeine, tramadol, ibuprofen, non-steroidals. We might consider offering amitriptyline neuromodulator medications like pregabalin or gabapentin, muscle relaxants for patients who have neck pain, but there is no sufficient evidence to suggest oral prednisolone or other steroids for those patients. I do not use steroids in my practice. Now, the natural history does have complications, and that's what I'm explaining to my patients when they see me and they ask, what if I leave it alone? The conservative treatment does carry risks and include worsening of the pre-existing cervical herniation, disc herniation, cause this herniation, which might result in radiculopathy, myelopathy, or even problems, vascular problems. And it might be associated with higher complication rates than previously reported. And sometimes the operation might be more difficult. So even no operation carry risks. The injections are always an option for those patients that have pain for more than 4 to 6 weeks. If the patient doesn't want operation, we can offer that as a pain management procedure. And it is also a good diagnostic tool when we have multiple level disease. That's the main indication in my practice. But I have to say, I suggest them less and less as the time goes by, because there is a question mark with regards to the effectiveness and obviously the possible complications. And in this article, they showed that the injections were effective in managing the pain and reducing the need of surgery for around 50% of the patients. Now, this is not much different than what we have in the natural practice. So the effectiveness is probably of low quality, and the benefits of the procedure are compromised by the possible risks. I can remember at least 2 patients who have had cardiac arrest during those neck injections. And I explained to my patients that I do other injections, the neck injections, I don't do them myself. And if everything fails, the next step would be surgery. This is exactly what I'm saying to my patients before the operation. This is on the consent form. The operation aims to decompress the nerve, neurological decompression, improve the radicular arm pain, in those terms, prevent further worsening, and optimize the potential recovery. So if a patient has neurological deficit beforehand, we cannot promise that it will improve, but we can tell them we give the best chance to nature for further improvement. The indications, clinically significant motor deficit, progressive deficit. This might indicate the operation will happen earlier. If the patient has impairment of the function, dexterity, dropping things, and debilitating pain that is resistant to the conservative management. The latter is the most common indication for an operation. The position of the patient, here we have a happy patient despite the intubation. We open the skin, we dissect around the skin. I like to dissect this layer anyway before we start. The incision depends on the level we want to approach. The C3-4 is just above the thyroid cartilage, the 5-6 is below the thyroid cartilage. These are the main areas of operation. And after we dissect the platysma, I used to do this vertical dissection. Now I prefer I went back to the horizontal incision. The closure of the wound is better this way. So after we cut the platysma, we identify the muscles. We push on the side the sternocleidomastoid, and medially we push the sternohyoid muscle, the strap muscles. We identify the carotid, not necessarily, but we have to feel to know where it is. After that, we expose the spine, we put the retractors, we have a good view of that. We do an X-ray to decide the correct level. I like to put a marker outside the spine. I don't use a needle in this stage. I do a second X-ray with a needle, but the first X-ray is with another marker. And after we see the correct level, we do anterior annulotomy. We have our retractors, the Caspar pins, go in the body, and after that we distract the level. And we insert after the decompression, we insert the cage, and we check with our X-rays that there is correct positioning. And most of the times, I do this operation without a plate for one level. For 2 levels, I prefer to put a plate on. Some people do the operation without a cage, the anterior cephalic discectomy. I don't do this operation. I always put something in the disc space. This is an operation where we put plate. As I said before, rarely I put for 1 levels. For 2 levels, almost always I use a plate. In the front, that's how we put it there. After we do the decompression, they put the cages. we insert the plate and we stabilize it with screws. This is the placement. It's quite important to notice that we have to remove those osteophytes so the plate will sit nicely on the anterior surface of the vertebral body. And that's the post-op X-rays. And this is a two-level operation. And this is the AP. The operation was done the last around, I remember, started around 20 years ago. This is the so-called disc replacement. The indication of this operation is mostly young patients, preferably 1 or 2 level disease without significant arthritis. So we have to avoid patients, we shouldn't be offering this operation to patients with significant arthritis simply because the level will fuse. The whole theory behind it is by removing the disc and put a moving cage between the two bones will allow to preserve some motion, and theoretically this will prevent further worsening at the adjacent levels. This is how we prepare the graft, the insertion of the graft, and the postoperative X-rays with a theoretical benefit of preventing the adjacent disease. This operation, again, anterior operation with drilling of the osteophytes on one level. I personally don't do this operation. Some of my colleagues like it. I think I'm working very, very close to the vertebral artery, and I don't do this operation. But effectively, it is a partial discectomy. We go on the side that is affected, and we drill the osteophyte in the disc, which compressing the nerve. The potential complications of the operation, this is exactly how I phrase it in my consent form and in my letter to the patient, the GP, including almost everything, very bad complications like paralysis, bleeding, swallowing, breathing disturbance. I even mentioned about life-threatening complications. Everything is in the consent form, so the patient is well aware. Which one is the best? There have been some trials. This trial was relatively recent trial comparing 3 operations, anterior cervical discectomy and replacement or arthroplasty, fusion, or anterior cervical discectomy without fusion. 109 patients. They compared quite a lot of markers, and the theory was that the arthroplasty is better than the others. But in the 2 years follow-up, there was no such finding confirmed. Again, we have to be careful about the follow-up, 2 years follow-up, because in a meta-analysis, if they had a look at the results at 2 years, there is no significant difference between arthroplasty and fusion. But after 5 years and persistently after 7 years, there is a statistically significant difference and having the arthroplasty better than the fusion. Yet again, you have to select your patients quite well. And there is a question if you can actually compare the two methods because the indications are not always the same. With regards to the posterior approaches, these are more or less all the operations somebody can do posteriorly in the spine, in the neck for decompression. For the radiculopathy, I do this operation, the foraminatomy, very concentrated on the side where the foramen is by drilling the inferior and superior laminae and going laterally to identify the root and decompress the root. Complications are more or less the same that I mentioned to my patient with the anterior operation, apart from the voice, swallowing, and breathing disturbance due to the approach. And we have to be careful how we close the operation. The posterior operation has higher risks of infection compared to the anterior one. And by closing the wound, I would like to conclude also my presentation saying that the diagnosis is the first step in the management of the patients, the cervical radiculopathy. Conservative treatment is always an option due to the favorable natural history. The surgery and the other invasive methods of treatment are reserved with a particular indication that we mentioned, and consider the risks, the benefits. And there is always a question, what is going to be the best option, and new technology will come across. So we will always have the question what to do next. Thank you very much.
Thank you, Nick. That was a complete coverage of cervical radiculopathy and stress and conservative management, specific indications. They have covered both anterior and posterior approaches in equal measure. And the new study which has come out, which is stated about arthroplasty being superior in long term, that is something which is new to most of us. Thank you very much for a very nice study, nice presentation, very informative. Now it's open for questioning and some discussion. To start with, Mridul.
Yes, good evening, sir.
Yeah.
Good evening.
Yeah, sir, so I just wanted to know, supposing there's a large posterior lateral osteophyte causing pure radiculopathy without any myelopathy and without any cord compression. So would you recommend an anterior approach or a posterior laminoforaminotomy with drilling of the osteophyte?
Yeah. In my hands, I prefer the anterior discectomy and fusion. As I said before, I generally don't do this microforaminotomy. Some of my colleagues do it. They are experienced in that. I have to say that you will see in our practice, we follow what we have been taught. And I don't see much of a reason not to do a fixation for somebody who has an osteophyte. The osteophyte at the end of the day is also the expression of nature trying to fuse the area. So I try to help the nature in this way. And sometimes osteophytes do regress with good fusion. So anterior, in this case, ACDF I would do. I wouldn't exclude the posterior decompression. Removing an osteophyte for posterior is, I would find myself difficult in my hands. But if somebody is experienced, I have heard of people who can remove even discs from posterior, but soft discs. For osteophyte, it might be a bit difficult.
Thank you.
Hardik. Hardik had asked a question. In the current scenario where there is no class 1 evidence of role of steroids, do you ever use a short course of steroids, say 5 to 10 days for severe radicular pain in patients not ready for surgery? Or do you persist with analgesics, relaxants, and pregabalin?
Yes. Generally, in my practice, I don't use steroids. It might be that I don't like them because I have seen quite bad complications with them. They might cause infection. They might cause thrombosis. We have to remember that those patients do have other comorbidities, sometimes gastric or diabetes. So I generally don't like steroids. I don't recommend the steroids, and there is very low evidence about that. On the other hand, an injection does have steroids inside. So when the patient is very keen to try something apart from operation, in this form, yes, I send the patient to one of the radiologists who are happy doing the injection. With regards to the muscle relaxants, again, I cannot remember when was the last time that I suggested diazepam for a patient with radiculopathy. For severe neck pain, we might suggest it. But again, for short term and not expecting miracles.
And I was asking how many months to wait before considering surgery?
Yes, the NICE guidelines talk about 4 to 6 weeks. In the NHS, it's extremely rare to see somebody before the 6 weeks. I would say 6 months probably we see the patients. So already the patients we see are filtered out. So we don't see the 70% of the patients who have already improved, or if they come to our office and say, it was bad, but now it's much better, I can live with it. And I'm definitely on this side, always try conservative treatment or continue it if it works. I would never ever suggest an operation for somebody getting worse. If we're getting better for radiculopathy. For myelopathy, even with very low symptoms, even without any significant weakness, if I see signal change in the spinal cord and increased reflexes, I am a little bit more aggressive. I tell the patients, we see every week one patient coming in with after a trivial fall or an accident, and most of them do listen to it.
So there are some questions regarding how to avoid dysphagia following the anterior approach. Any intraoperative tips?
Yes. Yeah. some of my colleagues, what they say, they deflate the cuff the time that they put the retractors. I think that the best thing somebody can do is careful dissection, preserve the normal structures, don't cut something if you don't know what it is. I don't try to identify everything. I know some of my colleagues try to do an anatomic dissection when they do, and like try to find each one nerve, each one vein, vessel, identify. I try to be as simple as possible, and the vast majority of the patients in the first 7-10 minutes, I'm doing the X-ray because I'm there in the spine. So after you do the initial dissection, you do a blunt dissection and you are there. The spine is quite straightforward.
Thank you very much, Nick, for a wonderful presentation. So there are a few more questions, which if you can please take some time to answer them in the chat box. So, Naren, can we go ahead with the next? Professor Jean-Paul Wolinski is with us here, so we'll go ahead with the next presentation. Welcome, Professor Wolinski. Professor Wolinski is Professor of Neurological Surgery and Orthopedic Surgery at Northwestern Medicine, Feinberg School of Medicine. Welcome, sir. So I request Professor to start his session on metastatic spinal disease.
So hello, thank you for inviting me, and I appreciate the course organizers for being able to put this on through Zoom. I think it's a great ability to actually get our students and residents and everybody else to see more than we would actually in person. But it's too bad we couldn't have done this in person, but this is great. So let me try to share my screen, and hopefully I won't screw this up. And let me know if you cannot see anything or hear anything, okay?
Yep. Oh, that's good.
Yeah, is it working?
Yes, it's working.
All right, so I'm going to talk about metastatic disease to the spine, and I'm going to take you through this the way I think about this somewhat historically, but also just taking it through how I think of things in a very simplistic way so that people can understand how to approach pretty much any patient that has metastatic disease to the spine. So when you think about metastatic tumors to the spine, we have about 1.5 million new cases of cancer every year, and 725,000 deaths from cancer per year. And this is in the United States. And the major cause of death is really complications related to metastatic disease. And the skeletal system is the third most common site of metastasis other than lung and liver. The spinal column is one of the most common areas, is the most common site of skeletal metastasis, probably because of its size and the number of bones in it. 90% of cancer patients will have spinal metastasis on autopsy studies, and 30% of patients with spinal metastasis will become symptomatic, with 20% of cancer patients with spinal involvement developing some degree of spinal cord compression. This is a slide from MD Anderson looking at a 10-year period from 1984 to 1994. This is obviously an old slide, but the numbers have probably gotten bigger, but the percentages are about the same still today. When you look at the distribution of different tumors that were admitted to the hospital, lung, breast, prostate, and blood tumors were the highest ones with metastasis to the spine. Oops, sorry. When you look at the metastasis to the spine, well, where do they go? I'm going to try to close this part. Majority of the metastasis will go to the vertebral body in about 80%, and the majority of the tumors will go to the thoracic spine in about 70%. That's probably because those are the areas that have the most vertebral bodies, and also the vertebral body is the larger segment of the spine, but it's also probably the most vascular area of the spine as well. And then we see metastasis obviously in the cervical and lumbar spine and in the posterior elements. When we think about metastasis of the spine, and we're dealing with a patient that you're evaluating as to how you're going to treat them, you really need to understand their neurology, but also their pain characteristics. And so simplistically, I think of the pain categories as 3 different ones: those that have local pain, axial pain, and radicular pain. And I'll take us through these different types. So local pain is really constant pain. It's not worse with movement or upright position. You don't get any relief when you're lying down. People will feel this throughout the night, throughout the day. There's no vertebral body collapse or spinal deformity. And we think that this is caused by periosteal stretching of the tumor. And here's an example of a patient with a metastatic breast cancer. And you can see that the vertebral body is completely involved with tumor, but there's no deformity of the spine. There's no spinal canal encroachment. The tumor is completely within the vertebral body. And this patient would really present with pain that's sort of a constant tumor type of pain. And then there's patients that have axial spine pain, very similar to what we see with our degenerative spine patients, but this is mechanical pain. It's worse with movement. It's relieved with recumbency. And these patients will have usually some sort of vertebral body collapse or spinal deformity, and they have a degree of spinal instability. So this is the type of patient that when you're in the hospital and you get called for a consult, the service calls you, it says this patient has severe pain. And then it's not infrequent for me to get a call back from one of my residents that's examined the patient, say, well, you know, the patient does have some deformity, but their pain isn't that bad. But if you ask them if they ever got the patient out of bed, they'll say no, because the patient was really hesitant to do it. And the reason the patient's hesitant to do it is because the pain is so bad, when they get out of bed, they prefer to be in bed. And this is an example of dramatic spinal instability, but you can see the entire vertebral body has been destroyed by the tumor, and there's a kyphotic deformity there at the lower thoracic spine. And you can also sometimes see bone in the spinal canal as well from something like this. Now, radicular pain is very similar to what we have with our degenerative patients as well. It's usually a constant type of pain. It can be made worse by positional changes. It's obviously in a radicular distribution, and that distribution might have pain that's in a dysesthetic type of pain, really sharp type of pain, lancinating pain, and it's from nerve root compression. So this is an old picture, and I don't know if you can see my mouse, but you can see that there's tumor within the vertebral body going into the frame and pushing on this exiting nerve root, and that'll cause radicular pain. When you think about tumors, you think about how you're going to manage them, and it's probably a simplistic way of thinking about it, but bony tumors, separate them into primary versus metastatic and what your general goals of treatment are. So with our primary tumors, our goal really is cure or long-term disease-free survival. With metastatic tumors, the goal is palliation, right? We are going to try to treat these tumors to help people feel better, but our goal is not to cure them with surgery. If anybody's going to cure or long-term disease-free survival, it's going to be given by our oncologists. The other big difference is that with our primary tumors, we don't have very many good adjuvant therapy options. With metastatic tumors, we have very good options for them. Traditional chemotherapies, but also newer adjuvant therapies like immunotherapies have significantly changed the profiles of how these patients will survive. The morbidity also, what we want to do for these patients is here our goal is palliation. So we want to try to have as little more potential morbidity to the patient as possible, because we don't want them to spend the entire rest of their life recovering from this operation, so their lifespan is short. And the type of surgery is also different, usually. So the majority of our surgeries for metastatic tumor will be interlesional tumor operations, similar to what we might do in the brain, compared to for our primary tumors where en bloc is usually the case. So now let's take a trip down sort of memory lane of how tumors were approached in the spine. So for a long period of time, really when patients developed spinal cord compression, we treated patients with radiotherapy alone. And if you look at papers that have been published on this in the past, really, if you had somebody with spinal cord compression and treated them with radiation therapy alone, about 44% of patients overall would improve and about 17% would worsen. Now, these are also, all these different papers are all over the place, and that's the general way of looking at things. Now, what happens if you add a laminectomy or decompression to that radiation therapy? Well, outcomes about actually the same. You still have about 44% improving and 13% worsening, but because you're adding surgery, you're adding mortality, so you have about a 7% mortality as well. And so for a long period of time, it was thought that surgery was not really a good idea with patients with spinal cord compression from metastasis. And so frequently these patients just went for radiation therapy alone. Well, what changed over time was that our instrumentation for the spine got better, and surgeons started using instrumentation that we had for deformity also in metastatic disease. And so with posterior laminectomy with stabilization, we actually now started seeing improvement in motor scores, so a 67% improvement, significant improvement in pain. We still had mortality, but this started shifting the paradigm of how people were thinking about things, and that with surgery, meaning decompression plus stabilization followed by radiation, they could have significant improvement compared to radiation alone. The same was true with ventral operations as well. And these papers, they tended to describe better improvement in motor and pain, but they're probably very similar. Roy Patchell, and this study took about 10 years or so to do. He first did a study with solitary metastasis to the brain, but then took it a step further and did solitary metastasis to the spine with spinal cord compression to see which was better, radiation versus surgery plus radiation. And so he did a prospective randomized trial for this, and this was first presented in ASCO in 2003. What he did was he randomized these patients to radiation therapy alone versus surgery plus radiation therapy. And at the time, radiation therapy was conventional radiation therapy. And then he stratified them by tumor type, ambulatory status, and spinal stability. All patients received high doses of steroids, and these are high steroid doses that are much higher than we would normally give for a patient that we're taking to surgery. But this was the dose that was given for patients that were undergoing radiation therapy with spinal cord compression, so it was felt to give it to everybody. The contributing institutions for this, Roy Patchell at the time was at University of Kentucky, so the majority of patients came from there, but other institutions provided patients as well. And if you see, MD Anderson provided about 14 patients. If you remember from my earlier slide, the number of patients that MD Anderson had seen and the number of patients that had spinal metastasis and the number of patients that had operated upon was significantly higher than this. And the reason why they only had 14 patients coming from MD Anderson at the time was because they had already made their decision that surgery was better. But the study overall was a very good study. And what he found, and Roy is a neurologist, not a neurosurgeon, so he's probably not as biased as we would be with a study like this. But what he found is that patients that underwent surgery plus radiation therapy did better from an ambulatory status. They continued to walk longer. And even non-ambulatory patients regained the ability to walk compared to those in the radiation therapy group. Some did in the radiation therapy group, but not as many. Time of continence was improved with surgery compared to radiation therapy alone, as well as the Frankel scores was significantly better with surgery compared to radiation therapy alone. Overall survival was not significantly different. So surgery itself is not improving length of survival, right? So that what you're improving is the symptoms, but the patients still are relying on their chemotherapy or adjuvant therapies for long-term survival. So the conclusion from this study was, and remember, this is for solitary metastasis with spinal cord compression, was that surgery plus radiation therapy alone was, surgery plus radiation therapy versus radiation therapy alone was superior. So what are our indications for radiation therapy? Well, tumors that are radiosensitive tumors, those are ones we really try to avoid surgery if we can, because the tumors will respond. Patients with a stable neurologic status, no instability, no bony compression, or patients with very limited life expectancy where you don't want to put them through such a surgery. What does it mean to have a radiosensitive tumor? Well, this is also a changing definition. So tumors are defined as very radiation sensitive based on how they respond to conventional radiation. This is not stereotactic radiosurgery, this is conventional radiation therapy. So it also is how much they'll respond without hurting the spinal cord or causing radiation-induced myelitis. So the very sensitive tumors are the ones like lymphoma, myeloma, small cell lung cancer. And the ones that we consider not very radiosensitive are colon, renal cell, melanoma, sarcoma, and squamous adenocarcinoma of the lung. This is a shifting thing because now with stereotactic radiosurgery, we can deliver high doses of radiation to a tumor. These tumors that we considered radio insensitive, like the renal cells and the melanomas, are now somewhat able to be treated with radiation therapy if it's stereotactic radiosurgery. It's not a given that they're going to shrink around or control them, but they have potential compared to where they didn't before. So When we look at a patient like this that has this constant periosteal type of stretching pain from a tumor that's involved in the vertebral body, no neurologic compromise, and pain doesn't change with standing up or sitting down, this is a patient that would be actually one that we would treat with radiation therapy alone, because they don't have spinal instability or neurologic compromise, and it's really trying to get their pain under control. What about our indications for surgery? Well, indications for surgery are to establish a diagnosis, treat spinal instability, treat bony compression, epidural cord compression with cord dysfunction in the non-radio-sensitive tumors, meaning that myeloma, lymphoma, these types of tumors, if you actually treat them with fairly low doses of radiation, the tumor can melt away overnight. So these are different kind of patients. Radio-resistant tumors, recurrence of tumor despite radiation therapy, which is not a fun time to operate on somebody, but it is something that we have to do sometimes. Neurologic deterioration during radiation therapy, or axial or radicular pain. So the spinal oncology study group, which later meshed into the AO tumor group, came up with something called the SINS score, or the Spinal Instability Neoplastic score. And this score hasn't been validated yet, but it's very useful for understanding how to differentiate which patients are considered stable versus unstable. And there are obviously going to be patients in the middle that are indeterminate. And this is probably more useful for the oncologist and the radiation oncologist for deciding when to refer somebody to a neurosurgeon for these types of problems. But it can be also useful for people that are trying to crystallize all of this in their mind. And so how they characterize these patients is, first they divide where's the tumor located, what is the pain like, is it how is the bone lesion, is it lytic or blastic, or is it mixed? What's the spinal alignment like? Is there any vertebral body collapse, and are the posterior elements involved? And each one of these has a different scoring attached to it, and you add up the score, and if it's 6 or less, then it's stable. If it's greater than 12, it's unstable, and if it's in between, it's unclear. So this is a patient that you can see that has a vertebral body collapse of L2 with epidural extension, and there's kyphotic deformity, and this person falls into the unstable category. And this was treated with an anterior and posterior approach to realign the spine and decompress the spinal elements in this area. The other thing you need to think about when you're thinking about operating on a patient with metastatic disease to the spine is, what is their overall survival? And again, this is a moving target. And this is an old slide, but I keep it because I think it's a great way to appreciate how things are changing. So really, you don't want to operate on somebody who has an overall survival of less than 4 months, because they're going to spend a lot of their time recovering from your surgery, and they might not appreciate the benefits of what you've done for them, and they might feel much worse than they would have otherwise. So it used to be our mantra that lung cancers, melanomas were survival overall of about 4 months or less. Well, this has really changed. So now with our immunotherapies, lung cancers can be surviving out several years, and melanomas can survive many, many, many years. So this is a really changing paradigm. And it's probably true for almost all these tumors about how things are shifting. Lymphomas, myelomas, I mean, the myelomas now, I rarely would see somebody who doesn't survive more than 2 years. So it's a very shifting paradigm, especially with the immunotherapies that we have. And that has to make us change how our attitude are towards these different patients. When you ask your oncologist what the overall survival expectations for the patient, it's very difficult to get an answer from them. But you need to use your intuition a little bit about the overall health of your patient. Surgical approaches. Well, if you're going to undertake these types of operations for patients with metastatic disease, you have to be familiar with all the different approaches so that you can get your patient through the different areas, right? Our workhorse of most things are laminectomies, posterior lateral approaches, anterior lateral approaches, and anterior approaches. You also need to understand what you're going to get yourself into besides just the approach to the tumor, right? Is this a vascular tumor? So many vascular tumors can lose a lot of blood in the time of surgery. So you want to try to minimize that if possible, and maybe even consider preoperative embolization for these. Things like renal cell carcinoma, thyroid cancer, hepatocellular carcinoma, pheochromocytoma, melanoma, sarcoma, Angioparasitoma and myeloma, if you have to operate on them, tend to be fairly vascular type of lesions. One way to remember how vascular a lesion is where is it coming from? Well, if it's a kidney cancer, it comes from the kidney. Kidney filters all your blood, very bloody organ if you operate on it. Same thyroid. So think about what the origin of that tumor is, and you can get a sense of how vascular it might be. What about vertebroplasty or kyphoplasty for metastatic disease? These are great options for patients that just need pain control, right? A vertebroplasty is where we put a needle, Murphy needle right into the spine, into the vertebral body, and inject cement under pressure. Kyphoplasty, put a balloon in to make space, and then inject methyl methacrylate to support the spine. Overall, there's probably not a significant difference between the vertebroplasty and kyphoplasty. Many times it's the radiologist's preference as to which to do in the different scenarios that they're working with. I don't think that the kyphoplasty really restores any of the vertebral alignment, but they both have great results as far as pain control in patients. And this is different than what we see with our osteoporotic compression fractures. So keep this in mind as an adjuvant option for patients. What about stereotactic radiosurgery? What does that mean? So we talked a little bit about conventional versus stereotactic radiosurgery, but newer advances for treatment of spinal disease is stereotactic radiosurgery. So one way to think about that is that when you're doing conventional radiation therapy, and I don't know if you can see my mouse, but the radiation comes from one point of the body through the body and radiates everything in between. And that you hope to get a certain dose to that retrieval body, but you're also getting a dose to everything like the spinal cord, lungs, and everything in between that area. With stereotactic radiosurgery, think of it as you're delivering a low dose radiation to a point, but you're giving lots of different beams from lots of different directions to that same point. So the intensity of that beam at that one point adds up so that you have a lot of radiation delivering to one area. And this way you can plan out where the spinal cord is, where the dura is, where the epidural tumor might be, and decrease the amount of radiation to the spinal cord or other important structures in that region. So in conclusion, just to summarize how to think about things, think about your pain as far as what the patient's presenting with, if that's one of the things they're presenting with. Is it local, axial, or radicular pain? Think about the spinal stability, but also think about your different treatment paradigms for treating that pain. Think about your radiation therapy and your different options, your surgical resection, what will be involved if in surgical resection versus vertebroplasty or other different devices for controlling pain for instability. And spinal stabilization is an integral part of your surgical procedure. So if you're going to decompress somebody, take the tumor out, you should always be thinking about whether or not you need to stabilize this patient. And I would say that probably 99% of these patients need some degree of stabilization because the spine has been destabilized to a certain degree by the tumor, and you're going to destabilize them further with the surgery that you're going to provide. And one of my mantras is go big or go home. So if you're going to undertake one of these operations, don't do some minimally invasive stabilization that may or may not hold up. You want to make sure that what you're providing this patient is going to be strong, because if you have a complication with your surgery, you've doomed that patient to a miserable existence until they succumb to their disease. And if you're going to undertake these, make sure that you're familiar with all the different approaches. So I'm going to leave that and answer any questions, assuming I can figure out how to get back to that part.
Thank you very much, Professor Wolinski. That was, as always, a very thorough and very lucid lecture on all the aspects of this dynamic area, that's the metastatic spine disease. While the audience email me with any questions, can I just ask you some simple practical questions that many of us, when I did spine surgery, used to face? If a patient comes with, let's say, coda equina compression, and it's late at night with the metastatic spine disease, and involving the vertebral bodies, would just doing, what would you advise? Would you still do it at night in Northwest, or do you have any, how do you approach, or how do you advise your residents to approach such cases?
Well, I think that it really depends on what your hospital has as far as resources and ability to do different things. And, you know, these cases are not necessarily small operations. And so doing something like this in the middle of the night with not your normal anesthesia team or the backup of that kind of thing can be problematic, but it really depends on the situation you're getting yourself into. And so if the patient can be temporized with high-dose steroids, I would do this operation as the first thing in the morning. If your gestalt is that they're not going to make it to the next day without losing all of their function, then I think you just need to pull the trigger and do the operation at that time. But I wouldn't do a small operation. I would do the operation that's needed at the time rather than thinking about doing something small and then bringing them back.
You might have covered, but I was moving around the systems in terms of if a patient is completely paraplegic and blood and bowels gone. At what point do you say, no, I'm not going to do it at all? Or at what point do you still go ahead? Or do you give a trial of steroids before you're deciding? How do you...
It's a very difficult discussion to have with the patient, but if they're complete, meaning no sensory, no motor, the chances of them recovering anything is pretty small. And because they have a limited lifespan, they also have a limited time to recover from their neurologic injury. So if it's been more than 24 hours, I think that offering surgery is probably not in their best interest, because surgery will also delay any adjuvant therapies that they might be needing, like chemotherapy, to keep them alive. And so, you know, the recovery time from surgery before they can get back to their chemotherapy might do them as well. And so they might be going through a lot for no real gain, or maybe actually worsening. So I think it's an honest discussion that you have to have with patients. I think that giving them a trial of steroids is useful to see if they will improve, but if they come in at that point, most likely they're not going to get any improvement. In my experience, you know, we always think about these patients that get acutely paraplegic, but in my experience, I don't think that actually really happens. I think what's happening is the patient's been slowly getting weaker over time, and they finally get to the point where they can't, that they've been in denial and they can't really justify the fact that they can't move.
Thank you.
That's an important point, as you said, Professor Jean, that it's a slowly progressive thing and they can't pinpoint when they actually became paraplegic. And when you see a patient like that, that was exactly one of my questions was to ask, suppose a middle-aged lady with a metastatic disease in the mid-dorsal spine, would you consider doing just a decompression if the medical oncologists say the survival is probably around 1 year from now without any fixation?
So if I were to do it, I wouldn't do it without fixation, just because I think that you'll make their pain significantly worse. So yeah, they might be paralyzed and maybe they're not feeling anything below that level, but the level above will become painful for them. So if you're going to do something, then I think you need to do the real operation. But if they've come in completely paralyzed and you're not really sure, maybe you're stuck with doing that operation, but usually you can tease out exactly when they sort of lost their function.
Question from Dr. Hesham Abolinin. I'm just going to ask the question for him because there are two mics there in case it starts a loop. He's asking how long you take to operate after radiotherapy. Many thanks for the nice lecture.
Right. So if ideally, I'd like to wait 4 weeks, but sometimes it has to be shortened. But 4 weeks is probably the ideal shortest time. Longer, better. But there are significant wound problems if you do it too early.
Another question from Dr. Galgano, Michael Galgano from Syracuse. Dr. Galgano, do you want to go ahead, please?
Sure. Hi, Dr. Walensky. Excellent talk. A quick question for you about your indications of doing separation surgery versus when you decide to do anterior strut cage or cement with like a chest tube reconstruction, something like what Zia would do.
Mm-hmm. So Mark, so for the participants that don't know what separation surgery is, so Mark Bilski, who's at Sloan Kettering, coined this term years ago. And essentially what he's doing or trying to describe is how do we take the pressure off the dura or the epidural space so that we can safely deliver radiation therapy to that lesion and to control the tumor with radiation. And so in order to do this, you need to be able to, number one, make space for the spinal cord and stabilize the spine, because you're still having to stabilize the spine. You also have to be able to deliver your radiation therapy in the form of stereotactic radiosurgery very soon after your surgery, so that you don't wait too long for that tumor to grow again. So if you're going to do this, you really want to plan your radiation therapy while the patient is recovering from your surgery. So if I do it, and I really pretty much have the same philosophy for any metastatic disease, but I start planning my radiation therapy while they're in the hospital, get my myelogram after surgery, start the stereotactic radiosurgery planning, so that at 2 weeks, I can give radiation therapy. So stereotactic radiosurgery you can give sooner to a patient than you can conventional radiation therapy. Now, if you have a complication in that time period, like an infection or hardware problem or something else, you might be delaying your radiation therapy, and then you're going to be chasing your tail. And so the question of when you do a bigger operation than a separation surgery, it really depends on what the tumor looks like and how much time you think you're buying yourself and how well that tumor is going to respond to radiation therapy. In my experience, it doesn't add that much more morbidity to finish taking out the entire vertebral body. Now, we don't do this as aggressively as we would with a primary tumor, but it gives me a lot more space that if the patient were to have a complication down the line with infection, it just buys me a little bit more time. So it's a balance, and you just have to decide with the different patients that you're looking at.
If I may ask just two conjoined questions. I'm sure you would have come across different practices. Some people are very aggressive, some people are more on the conservative side. Obviously, every surgeon does what he thinks is appropriate, but is there any rational way of trying to standardize who gets operation, who doesn't get operation? Because I'm sure if you put up cases, you will find that it's a bell-shaped curve in terms of some people going for everything. Is there any way, from a patient's point of view, which day is he turning up in the hospital and who's on call? What's your thoughts on that?
Yeah, unfortunately, it's very difficult to standardize because things are all over the place. I mean, there's really only that study from Roy Patchell that looked at metastatic tumor to the spine. And really, when you look at that paper carefully, it's solitary metastasis of the spine. So it's not like there's the usual patient where they might have a lesion here, another one there, and whatever, and you're trying to decide what to do with these patients. And you're right, it depends, in many institutions, it depends, number one, who's on call, but it also depends a lot on the oncologist and whether or not they believe in surgery for their patients. And so a lot of it is education on the parts of the surgeons to the oncologist to demonstrate what benefit that they can give to their patients. So if you're a very aggressive surgeon, you operate on every patient that has metastatic disease, you're going to have many complications in patients that don't get better from your surgery. And probably after a short time, the oncologists are no longer going to refer patients to you. So you have to be very selective to make sure that the patients that you're operating on have the best chance of actually improving from your surgery and not just provide it to everybody. I think that the way that this can work best at an institution is if you have certain surgeons that are dedicated to tumor work. And also if you have an integrated sort of tumor board between the oncologist, the surgeon, and the radiation oncologist, so that each patient has a good assessment by all three groups so that it's fairly balanced.
Thanks. I think there are many young neurosurgeons in this webinar. In terms of career choices, obviously metastatic spine disease is going to be always there, but I did a fellowship over a year, and in spinal metastasis, even on the 1 year, the number of cases started to go down, the number we operated. What's your thoughts with the increasing sophistication of the adjuvant therapies? Is that what you are seeing in North America as well?
Well, it's always a shifting kind of a shift in what's going to happen, because when I first started this, it was the idea of whether or not patients should actually have surgery, right? The radiation versus surgery kind of debate. And then it shifted to, okay, everybody should have surgery. And then after stereotactic radiosurgery came around, it sort of shifted a little bit back to this separation surgery concept, or maybe getting away with not operating. And with adjuvant, and then, as life expectancies for patients improved with some of these adjuvant chemotherapies or immunotherapies, more patients in certain ways are having more complicated spinal problems. And so it's shifting again towards those types of patients for surgery. So it's a constantly shifting thing. I do believe that the role for surgery is always changing, and you have to be very flexible. What I tell people that ask about a career in spinal oncology, or even doing a fellowship in specifically just spinal oncology, I say you have to be very careful about that, because there's very few careers out there where you can just be doing spinal oncology. There aren't very many centers where they can support that. So if you're doing it, you have to be flexible and be interested in doing other things as well, because it probably isn't going to be enough to satisfy your career in most places.
Thank you. The final question is from Dr. Arijit Chakraborty. Dr. Chakraborty, do you want to introduce yourself, where you are coming from, and ask the question, please? Thanks. Chakraborty. So I will ask his question. Dr. Chakraborty, do you want to go ahead?
Yes, sir.
Please introduce yourself. Where are you calling from? And
I'm from Bangalore, neurosurgery resident here from Municipal Hospital.
Sure.
I had a question, sir. If a patient with paraparesis and is having one primary follicular thyroid mass, and it is extensively involving the thoracolumbar, vertebral body, and posterior elements also. So before going ahead with the surgery, should we consider embolization also?
I would consider that if you have the time to do it, right? Because those tumors can be very, very vascular, and if you can embolize it, then you're going to probably improve your vascular control and decrease the amount of transfusion. Now, it's interesting, whenever you talk to a interventional radiologist or interventional neurosurgeon, they always say that it decreases the bleeding. There's no way to prove that because it's not like you have the same patient that you can embolize and not embolize. But if you can do it, your experience in the operating room will be significantly better. In the operating room, you can, even from a posterior approach, you can get lateral enough and find those segmentals and ligate them yourself before they give feeders to the vertebral body. But you have to get pretty lateral and anterior to do that. If you have experience with that, you can control the vascularity that way. But if you can embolize it, you're usually better off.
Okay, thank you.
Dr. Professor Wolski, would you be kind enough to just answer one more question? I will read it out. It's an important question. If the bones are not, what do you call, strong enough, what would do you have any advice in terms of fixing such patients for metastatic spine disease?
Yeah, so it's not uncommon for the bones to be softer than our degenerative patients, just because these patients can be older and they've seen lots of different things that will decrease their bone density. So sometimes you do need to augment the vertebral bodies for the screws. Either you might, nowadays we have a lot of screws that are fenestrated, meaning they have holes in them where you can inject methylmethacrylate down the screw after the screw's been in place, which makes it easier. But if you don't have that kind of technology, then you can place your holes for your pedicle screws and fill those holes with methylmethacrylate, and then place the screw down there to add some added rigidity to that fixation as well. The other option is to think about older things that we used to use, like hooks and wires. So pedicle hooks can actually be surprisingly strong in combination with pedicle screws to improve your pull-out strength. And so adding a hook above or below that construct can be very helpful sometimes to improve that strength, or even adding wires to the pedicle screws around the rods to hold things in place.
Thank you very much, Professor Wolski. That was fantastic lecture and fantastic questioning. I hope you also found it rewarding. I hope to have you, look forward to have your next lecture in the next meeting. Thank you very much, sir.
That's great. Thank you very much. You guys enjoy your time on the meeting today.
Thank you. Thank you. So now I will introduce Dr. Galgano, Dr. Michael Galgano. He's the director of spinal tumor section at the State University of New York in Syracuse. It's a real pleasure. It's a department that I have many friends, and it's an honor to have Dr. Galgano speak to us. Dr.
Thank you for
Galgano,
having me.
Thank you. It's our pleasure. Dr. Galgano, do you want to share your screen, please?
Sure. All right. Are you all able to see this?
Yes, we can. Yeah.
All right. So thanks again for having me. I'll be talking on the surgical management of intradural extramedullary spinal tumors. I'm going to preface that by saying some of these tumors, such as schwannomas that typically are intradural extramedullary, they can also have extradural components to them or completely be out of the dura, out of the spinal element. So I will touch on some of those as well. I have no relevant disclosures for this. So the term intradural extramedullary essentially means that these are tumors of the spinal cord, but they're arising within the dura mater, but they're actually outside the confines of the spinal cord parenchyma. And about 80% of these are schwannomas, neurofibromas, and meningiomas. And then the rest will make up things such as sarcomas, epidermoids, and cystic type structures. And I'm going to focus on the main types, which are neurofibromas, schwannomas, and meningiomas. And towards the end of the lecture, if we have a few more minutes, I'll show some more unusual cases. So surgical approaches are pretty basic for this. It's usually a posterior soft tissue dissection with a laminectomy, laminoplasty. Obviously, the approach will vary based on the location of this. Is it cervical, thoracic, lumbar? Is the tumor located in the ventral component of the spinal cord or the dorsal, or is it a combination? Consistency plays a role as well, as it's a very heavily calcified tumor. That's going to be very difficult to get from an all posterior approach, or is it soft and friable? And obviously the size makes a big difference as well. So basic surgical approach, I think most of us use laminectomy. The way I do this, I try to take everything out en bloc if I can. I'll drill troughs on the sides of it and then take it out in one piece. That way we can utilize it for bone graft if there needs to be a fusion, or for a laminoplasty by putting some plates on the side. This is a short video clip, just a basic approach here. We take the interspinous ligament above and below down. I like to use a coarse diamond drill bit. Some people do think that this particular bit is very slow. I think if you know how to use it properly, it'd actually be very expeditious, and it's actually very safe. So I use about a 5 to 6 millimeter coarse diamond drill, and then I drill troughs on both sides, get underneath the ligamentum flavum, and take it off in a single piece. After that, typically we'll bring the ultrasound in, the Aloka device, as a secondary confirmatory marker that we're at the correct location. And then this is just typical durotomy, where we'll just open it up with an 11 blade, typically put a dental tool or Woodson beneath it, and then subsequently use micro scissors to finish opening it up. This particular tumor, I won't go into the entire case, has actually ended up being in cauda equina ependymoma. Rotating the spinal cord, this is an important concept when you think about taking these tumors out. This is very relevant for anteriorly situated tumors. If it's a soft tumor, we can always cut a dentate ligament, as you see in the bottom picture here, put a Prolene or a Neurline stitch on that, and then gently rotate the spinal cord. Typically, the spinal cord will tolerate some degree of rotation, and however, it does not like to be stretched out. That being said, there are some very large ventral tumors. Some of them are very firm, rubbery, calcified, and I'll go into some of those cases later where even using methods such as clipping thoracic nerve root and a dentate ligament and trying to rotate the cord is still not sufficient to get a safe resection for that. So meningiomas, as we all know, these originate from arachnoid cap cells. They're typically seen in the thoracic spine. There is a female preponderance for these, potentially due to receptor subtypes. And these are almost always intradural and dural based. On occasion, you can actually see extradural meningiomas as well. So I'll go over a series of cases. I'll try to show as many videos as I can in the next 20 or 30 minutes. I don't have a video for this case, but this is a very bread and butter case. This was a 37-year-old lady who came in to our hospital about 8 or 9 months ago. Her presenting symptoms was leg numbness, legs were giving out, and she actually had band-like right-sided chest pain, most likely from a thoracic radiculopathy. And this is a very bread and butter meningioma. This nicely situated, it's dorsal for us, and we were able to take this out en bloc in a single piece by just doing a simple laminectomy. No fusion is indicated here, and the patient did quite well. We have to think about the resection technique. Do we take these out piecemeal? Do we take these out en bloc? Anytime I deal with a primary bone tumor or a primary spinal cord tumor, I typically will try to stay out of that tumor for as long as possible, if not completely. I think that you get a better oncological outcome, first of all. And second of all, I also think that you avoid a lot of bleeding by not getting into the tumor. One of the questions I've always had about spinal cord meningiomas is it necessary to actually take the dura like we try to do with intracranial ones? And Ziago Kassen, who I did my fellowship training with a year and a half or so ago, a nice study came out of Brown University basically showing that there was really no oncologic benefit for excising the dura with the meningioma. If anything, there was a slight trend towards more complications doing that. And I think this especially holds true if you have a ventrolateral dural involvement. It's very, very difficult to actually reconstruct the dura in those situations. Back to the case we just did, this is the post-op imaging. Again, it just shows we did a basically laminectomy and a half here, able to take this entire tumor out, and this patient did quite well afterwards. Schwannomas, these arise from Schwann cells, posterior spinal roots. Typically, they arise from a dorsal root. On occasion, they can be from a ventral root as well. And these are some of my favorite primary spinal cord tumors to take out because they could really be anywhere in the body. And I'll show some of these more bizarre schwannoma cases a little bit later. So they can involve multiple spinal segments. As we said, this is, again, a very bread and butter case, a 78-year-old gentleman who came to my clinic last year. He had ambulation intolerance, neurogenic claudication. He had thigh pain, unable to fully empty his bladder. He was getting up multiple times a night, urinating. This was actually one of his main complaints, believe it or not. He was constipated, but otherwise really neurologically intact. And as you can see at the thoracolumbar junction around the conus and the takeoff of the cauda equina, he's got this cystic looking lesion here. This is very consistent with the pretty run-of-the-mill schwannoma. We were able to take this out. These are not easy cases, though. Reason being is that some of these cystic schwannomas, they're very friable, and they're wrapped up in the upper cauda equina. And obviously, you can't take these nerve roots, so a lot of times in a post-operative imaging, you'll actually see that there's still a very subtle enhancement of some of the cauda equina here. As you can see here, again, it's very small, and we just follow this over time with serial MRI scans, and the majority of these don't grow back, but it's almost impossible to get a complete en bloc resection of some of these very friable cystic schwannomas of the cauda equina. They're actually much easier to take out in the thoracic spine. So this was a nice case. This was a T11-12 schwannoma we took out. And this is a case of a 37-year-old gentleman. I actually tried to talk him out of surgery because the schwannoma was so incredibly small, but it shows some nice anatomic features that I wanted to present here. So he basically presented with a history of low back pain for a few years. He's a construction worker. He had an MRI scan. And incidentally, it found a very, very small tumor here. It's basically in the thoracic spine, right at the takeoff of the cauda equina. And I told him this is probably a benign schwannoma. Why don't we just watch it over time? But interestingly, he had a recent history in the last several years of rhabdomyosarcoma and also had a history of a Wilms tumor as a child. So he talked me into taking this out and he was quite worried that this could potentially be a metastatic, a distant met. So we did take it out. Here's the surgical video of it. Typical laminectomy exposure here, no fusion indicated. We did our dural opening. We have our dural tack-up stitches here. This is our arachnoid dissection, which I like to use with the angle ball dissector. These serpentine vessels on the surface here, very common. And this is a nice concept I wanted to show because this is such a small tumor. You can actually see the anatomy quite well. An important concept is the concept of the common arachnoid sheath between the nerve root of origin and the corresponding nerve root. So what you can see here is this is the nerve root of origin here. And it typically has this small squiggly looking vessel. And then on the previous slide, you can see that was the corresponding nerve root. And that's typically the ventral root, the rootlet. And that usually needs to be dissected off of the tumor. The dorsal sensory root typically can be cut with impunity here. We obviously still do stimulate it. And then we're able to just cut this. But some of the largest schwannomas in some of the surgical videos, it's very difficult to actually see the corresponding nerve root and the nerve root of origin. But because this is such a small tumor, you could actually see it quite well. That's why I thought I would share this video. And we had a nice resection there. This is a case of a young lady, another 37-year-old who came to us. This was during my fellowship at Brown University, who came in with the C6-7 schwannoma. She had progressive loss of her hand dexterity. She developed numbness, gait imbalance, brisk reflexes throughout. And this is what her preoperative MRI on the left, T1 with contrast on the right. This is our T2 weighted image here. And a few intraoperative shots here. We were able to do laminectomy here. We did end up taking some facet down to make sure we got ventral. So we actually did do some lateral mass fixation as well. This is our dissection here of the arachnoid. And as you can see, this is not an easy tumor to take out en bloc. Can it be done? Potentially, but you obviously do risk causing some traction injury to the cervical rootlets and to the spinal cord itself. So we decided basically to use a CUSA to core this out. And then I'm not showing the whole video here, obviously, and then able to kind of fold this in on itself and then take this out in a piecemeal fashion. So this is the typical view of what you would look like for a cervical schwannoma. And we had a nice resection here in this patient. On occasion, we do come across these extradural type schwannomas. 81-year-old male I took care of a few months ago. He came to me with a painful enlarging right posterior neck mass, neurologically intact. And we did some serial scans on a gentleman, and this was actually growing pretty rapidly. And he had a history of nasopharyngeal carcinoma, and we were actually worried that this could potentially be a MET. So I did get this biopsy beforehand, but it was consistent with a cystic schwannoma. So we were able to do a muscle splitting approach here, did a paraspinal incision. We did a splitting of the splenius capitis muscle here. We got to the tumor. This ended up coming off the C2 nerve root. Luckily, he actually had no sensory aberrations in the back of his head after surgery, but we did have to take the C2 nerve root as this tumor was directly coming from that particular neural origin here. And we were able to take this out in a single piece on block here. And he did quite well after that. Neurofibromas, these typically are a lot harder to separate from the nerve root. It's almost nearly impossible to do that without sacrificing the root. However, in a lot of these circumstances, the nerve root is actually non-functional. The majority of these tumors are intradural. However, you can actually see extradural components with it. On rare occasion, in patients with neurofibromatosis, we will see a patient that has profound malignant degeneration of this. About 5 to 10% of patients with NF1 will develop a malignant nerve sheath tumor, particularly of these plexiform neurofibromas. This was a very challenging case. I did with Ziego Koslin during my fellowship. We ended up doing a 5-level vertebral column resection. We made a bold attempt to take this out on block in one piece. We were able to. We had to have the thoracic surgeons involved. Unfortunately, we had a CSF pleural fistula, and this patient had a slew of complications. This is a very, very challenging disease to take care of, though. This is a case I did about 3 or 4 months ago. I don't like to brand myself as a minimally invasive surgeon. I do a lot of deformity and open spinal oncology. However, there are some indications for doing this through a tubular retractor. This is a 32-year-old gentleman who came in. This was actually same-day surgery. He has a history of NF1. He presented with several months of left eye pain and numbness and otherwise neurologically intact. As we could see, at the L1 region, he's got this fairly large tumor. Looks like it's consistent with some type of a nerve sheath tumor. As one of our previous speakers said, we could potentially do a facetectomy, a posterior midline approach, and have to do a fusion here because the facet joints are so close together in the upper lumbar spine. Alternatively, you can do a minimally invasive approach, which is what we did. We put our serial K-wires and dilators in. Here's a surgical video, which we're able to employ. We did a paraspinal incision, very small, probably about 3 or 4 centimeters. We localized the transverse processes with x-rays. This was a little bit of a surprise we came across, was a daughter nerve sheath tumor that was actually posterior to the intertransversalis membrane here. This is a very key component. If you are going to do this particular surgery, you have to be very familiar with the anatomy here. So I'll go over this one more time. Just to go over the anatomy, here's our tubular retractors in place. This is the daughter tumor that we found. Below here, this is the transverse process of L2. This is the transverse process of L1, which is being hidden by the suction device here. This is the L1, L2 facet, T12, L1 facet, and this is the pars interarticularis here. And this here is the intertransverse membrane. And you're not going to get to this tumor until you cut that. That's a very key anatomic feature here. So after we took out that daughter tumor here, we cut the intertransverse membrane. We were able to access the tumor here. You will come across down bottom right of your screen. That is the L1 nerve root, and it is intimately, completely incorporated with the tumor as neurofibromas are. We obviously stimulated it. It was completely non-functional, so we were able to bipolar it, cut it and divide it, and then eventually take this out on block with the rest of the tumor. And this patient did quite well. His leg pain got better. He actually went home about 2 or 3 hours after surgery. And this does show the benefits of a less invasive approach to this, as opposed to doing a typical posterior approach, facetectomy, and a fusion. This is a more typical lumbar. This is a dumbbell type of a schwannoma. A 53-year-old gentleman who came in about 6 months ago to our clinic. He had low back pain, ambulation intolerance, left lower extremity discomfort, and numbness. As you can see here, another cystic schwannoma enhancing out into the L4 foramen here. You can see that there's another component of the tumor. If you look at the far lateral, the entire L4 foramen to some extent is filled up with tumor here. And this is the T2 showing the cystic component of it. And here's a surgical video. Again, typical laminectomy. We actually did end up doing an L4-5 fusion in him as well, because we did take the facet down in an effort to get very far lateral to take out the foraminal component of the tumor here. This is just showing getting the rostral margins of the tumor. With this particular type of a tumor, it is very challenging to take out on block, because in the lower cauda equina, these tumors, especially the cystic kind, they're very friable. They are intimately involved with the nerve rootlets here. So we did use a sonopet. If you're not familiar, sonopet is just like a CUSA. It's an ultrasonic aspirator. So we cored out the tumor and then basically peeled it off the ventral dura here. And then once we excised this piece here, we were eventually able to turn our attention to the foraminal component of the tumor as well. And we had a nice resection here. Obviously, because this is intimately involved with the cauda equina nerve roots, it is difficult to get a complete resection. So there are a few small nubbins of tumor that are left onto the nerve rootlets here. And you can see on the post-operative imaging, we had a nice resection. Even with instrumentation here, we still were able to get a good visualization of everything. And if you do look closely, there's small punctate little areas of enhancement. Is profoundly better than the pre-op imaging, but you can still see though that these are small nubbins of tumor that are left over that are stuck to the cauda equina here. So when we do all these surgeries, there's a lot of approach considerations. Those are some basic bread and butter operations. It's important to realize that not every case can be done with the standard approach. Some of these tumors, they do extend beyond the margins of the spine. And you do have to keep in mind that your approach may affect the global spinal alignment. I understand this is not a deformity talk, but I think it's important to touch upon these topics very briefly, especially when you're dealing with cervical spine. If you do a multi-level laminectomy, and you don't do a laminoplasty, you don't do a fusion, you have to take into consideration that you could potentially be setting the patient up for biomechanical failure in the future, whether it's a coronal imbalance or more likely a sagittal imbalance. So we have to keep these things in mind. It's very important to get preoperative x-rays in all these patients. Again, as neurosurgeons, we're focused on taking the tumor out. If you don't get preoperative x-rays, though, you may miss something very significant. It's important to look at the frailty index of these patients. Some elderly patients where we perform posterior approaches of the cervical spine, we have to keep in mind that they may have very poor extensor muscles, splenius capitis and whatnot. And if we do a laminectomy, there's a decent chance that if they have something like a very high T1 slope, they may not be able to compensate with cervical lordosis to maintain horizontal gaze after. So these are important concepts. Now, this is not an intradural tumor. But this shows, this is the case that was done in the community of upstate New York a couple of years back, and the patient was sent to me with the chin on chest deformity. And just to go to show you, this patient went to the operating room for a 3-level laminoplasty. Upright x-rays were not obtained on the patient. And you could see over several months, the patient developed a very profound deformity. And the patient was treated for about a year and a half with physical therapy, neck traction, putting the patient in the hard cervical collar. And the deformity just kept worsening. And my point here is that if we don't pay attention to upright x-rays, even though we're focused on, we may do a great job taking the tumor out, we could set the patient up for failure down the road. This patient ended up requiring a front and back operation to correct her deformity. So it's important to keep in mind, if we are going to employ something like a laminoplasty or a laminectomy without a fusion, make sure that they have the proper deformity parameters. Make sure that if they're elderly, we look at the paraspinal musculature, things along those lines. Again, I'm not going to belabor this point, but it is important to keep this in mind, because we could potentially develop some very heinous deformities even after doing a very good job taking the tumor out. There are some cases where a posterior only approach will just not cut it. There are some significant challenges getting around the spinal cord with particular tumors such as this. This is a ventrally located tumor. These are very heavily calcified meningioma tumors here. Rotating the cord, like we touched upon before, is a good technique to get ventral to the spinal cord, but that's not always plausible. So there's a few challenging cases I wanted to bring up where these basic techniques basically failed. These are a couple of cases that were actually sent to my radiation colleagues, radiation oncology colleagues, up in upstate New York. This is the patient who came in with thoracic myelopathy, and they have a heavily calcified upper thoracic tumor here, is consistent with the meningioma. And as the surgeon made an attempt to take this out and rotate the spinal cord by doing a straight laminectomy, multi-level laminectomy actually, they basically lost their neuromonitoring data, and they had to get out of this surgery and basically abort. And the patient was sent to radiation oncology for subsequent radiotherapy. And as you can see here, this is heavily calcified. It's stuck to the ventral dura. And it makes me wonder if we did a more aggressive approach, where the surgeon who ended up doing the surgery took a facet down, maybe drilled the pedicle down. It may require an instrumentation potentially, but it allows you to get the tumor out safely. This is a very similar type of a case, patient who presented to our radiation oncology colleagues for postoperative radiation due to inability to take the tumor out safely. This is actually an intradural chondrosarcoma. It's very rare, but again, they did a standard laminectomy based on operative notes and whatnot. They were unable to rotate the spinal cord safely to get access to this. They did get a biopsy of it, but they were unable to take the tumor out due to data changes, what are intraoperative neuromonitoring, motor evoked potentials, and somatosensory evoked potentials. And the patient ended up going to radiation for this. And even though it looks like that the tumor has shrunk in size to some extent, the patient now has radiation myelopathy. And this last case, it's a very challenging operation, is one of my own. This is a case that I did, one of my first intradural cases as an attending close to a year and a half or so ago. Patient who came in with non-small cell cancer, cervical myelopathy, and you can see she has a little bit of epidural disease down here, but we decided to focus our attention on this. And I tried to do a very small approach because she was a bit elderly, had cancer. So we tried to do a hemilaminectomy, hemilaminotomy, take down the part of the posterior arch of C1 and C2. And just from taking that arch down, we took the tamponade off the spinal cord, cord rotated, and we basically lost data on the side that we were trying to take the tumor out. So eventually things did come back. The patient thankfully woke up neurologically at her baseline, but we were not very aggressive with this tumor. And in retrospect, had it taken a more aggressive approach, maybe done bilateral laminectomies, take the facets down, even at the level of C2 where the canal is quite wide, my approach obviously did not cut it in an effort to be able to take this out. We did decompress it. She subsequently got radiated. But again, these are some challenges that we run into with some of these ventral spinal tumors. In the top right here, you can see this is actually a case from Dan Rue in New York City at Columbia University. This is a case he shows at a lot of his talks. A young lady as a 14-year-old had an intradural tumor resected. There was no laminoplasty, no laminectomy, and many years later, she presented to Dr. Rue with the profound cervical sagittal plane deformity here. So these are things that we do want to try to avoid. There are some cases where we do have to employ instrumented fusion afterwards, even with intradural tumor resection. So obviously there's some major pros, may lower the chance of postoperative deformity. It does allow us to get aggressive bone removal, taking the pedicles down, the facets down, getting flush with the disc in the posterior vertebral body wall. And it does allow us to access the ventral corridors of the dura. We have a very direct line of sight, and I'll show you a few of these cases. And there's really no cord manipulation with these. And this is essentially the tenet of skull-base surgery, where we try to maximize bone removal, minimize brain retraction. It's the same thing with some of these calcified, hard, rubbery tumors in the spinal cord. We try to do the same thing. Obviously, the cons with instrumentation are that there are inherent risks of instrumentation. Surgical time is increased. And then you have to talk about hardware artifact in a postoperative period. Now, there are some surgeons, I know Dr. Fessler speaking a bit later on endoscopic spine surgery. I am not exceptionally facile in this yet. I'd like to get there, but in my training, I did not do a lot of this, but there are, I'm sure, some of these tumors I may show you that maybe someone that's very experienced like a Dr. Fessler would be able to take out some of these tumors through a tubular retractor or even through an endoscope, as opposed to doing a very large bone removal like I've done in the past here. So that's definitely the wave of the future, is endoscopic spine surgery. In regards to hardware artifact, there is something new that's been coming out. They're called carbon fiber screws. I do think that this is the wave of the future to some degree with spinal oncology, even with some intradural cases, especially with metastatic disease, like some of the cases that Dr. Belinsky showed previously. This will profoundly help our radiation oncologists in the postoperative period to deliver adequate radiation without hardware artifact. And if we do have to employ instrumentation to our intradural cases, we can also better follow the tumors as well. So these are a few interesting cases that I've come along in the last several months. This is a lady who came to my clinic. She presented to an outside doctor initially with a degenerative spondylolisthesis, L4-5, and she had a fusion. This was a community orthopedic surgeon, and the patient came to me for a second opinion after surgery because she was having balance problems. She cannot stand up straight. She was very hyperkyphotic in her thoracic spine. So on her clinical exam, she had hyperreflexia, clonus, brisk reflexes, all typical signs of thoracic myelopathy. She could actually barely stand without walking. And essentially what we found here was that she has two spinal cord tumors, and these are consistent with meningiomas. This is our contrasted scan. You can see it's a very ventral meningioma here. This is the spinal cord draped around it. And at this level at T10 here, this is a small nugget of spinal cord pushed all the way over here. If we look at the CAT scan, this is a very hyperdense lesion. And there's actually some hyperdensity as well to this one. So this particular case did worry me in regards to doing a standard laminectomy, being able to take these out safely. Here's a surgical video of what we did. So we did take down some facet joints. We did drill down some pedicles here in an effort to get a ventrolateral access to the spinal cord. Again, this gives us a beautiful direct line of sight here. We do not have to rotate the spinal cord at all. These are actually cord vessels here. These do not belong to the tumor. So we had to dissect these off. We try to shrink the tumor as much as possible, devascularize it. This is just peeling the dorsal arachnoid off. We don't see it in this video, but there was actually a very large piece of tumor on the contralateral side beneath the ventral arachnoid as well. And then we'll just get bipolar cautery, try to take this out on block if we can off of the dura here. After we took this out, we closed up the dura, and then we paid our attention to the upper meningioma here. This cord at this level was very, very sensitive, even despite the fact that we took a ventrolateral approach. We did have some very temporary spinal cord data changes, which thankfully did come back by the end of the operation. But the spinal cord is very sensitive here. So again, I don't know that the cord would have tolerated being rotated at that particular level. So we did end up instrumenting this patient. A big reason was because we took facets down, we took pedicles down at 2 levels, and also because you can't appreciate it on the supine CAT scan, but she was very hyperkyphotic as well. And she did fabulous after the operation. Very similar type of an operation. Instead of meningiomas, these are ventral schwannomas. Again, the patient presented with an L4 spondy to an outside surgeon in our community. And what they missed was that there's a small ventral intradural tumor that's up here, but it's actually much more than just a single tumor. When you image her thoracic spine, this lady could actually barely walk. She had a neurogenic bowel and bladder, clonus, brisk reflexes. We actually find 5 ventral tumors here. These are consistent with nerve sheath tumors. Again, I was particularly concerned about taking this tumor out and this one because the spinal cord is completely draped around this particular tumor over here. So we did do an aggressive bone resection here. You don't see it here, but this is actually flush with the vertebral bodies. This is the contralateral lamina here. So again, this is a ventrolateral durotomy that we're undertaking here. We did use instrumentation for this. This is us cutting the arachnoid. These are our thoracic nerve roots here. And this gives us a beautiful line of sight directly of all 5 of these tumors without any spinal cord manipulation, no cord rotation at all here. And we're able to essentially take all 5 of these tumors out in an en bloc fashion here. Again, these are all nerve rootlets, thoracic rootlets, and we could take these with impunity. We're not going to cause any type of postoperative deficits here at all. This is what things look like after. So again, this would have been a typical dorsal durotomy. Could we have gotten ventral without instrumentation and taking the pedicles down? Potentially, but I do suspect over multiple levels, this would have caused a lot of traction on the spinal cord. So we took a bit more of an aggressive approach, but we were able to safely take these out in about 2.5 hours. This is not an intradural case, but it is a schwannoma. I'll show a couple more of these that are outside the confines of the spine, time permitting. This is a 67-year-old lady. She had a history of a known S1 schwannoma. It started off at the L5-S1 junction, migrated through her S1 dorsal and ventral foramen, eventually situated itself in the presacral space here. I did get a lot of opinions on this, and multiple people had actually suggested to get a surgical oncologist or colorectal surgeon involved. We decided to do an all posterior approach here. You can see that the tumor is intimately associated with the iliac vessels here. So we basically did a mini open approach, a unilateral approach. We basically widened the dorsal S1 foramen. As you'll see here, this is caudal, this is cranial, this is medial and lateral here. This is us just cauterizing the capsule of the tumor. We tagged the capsule of the tumor with Neurolon stitches, which is here. And basically we were able to get this entire tumor out in a piecemeal fashion from a mini open transsacral approach just by widening the dorsal S1 foramen. The S1 nerve root is associated with the tumor. but we were able to completely keep it intact, actually. And this is the final delivery. Obviously, this was about 2 or 3 hours of wrestling with this tumor before we got the final product out here. And we were able to see the retroperitoneum pulsating over here. We took that small piece of tumor out as well. And then we kind of just reconstructed this. We put some dural sealant here, even though there was no durotomy, and subsequently a piece of DURG in here. And you can see that we got a nice gross total resection from a transsacral mini open approach, even of this fairly large presacral component of it. This is probably one of my favorite cases I've done as an attending in the last year and a half. This was a lady who came in, 57, typical symptoms of thoracic myelopathy. She has a very large tumor here. Quite certain that this was a posterior mediastinal schwannoma, but we did get it biopsied and it was consistent with that. The tumor eroded through the facet above, the facet below, the superior part of the facet, pedicle below, and completely took out the pedicle and part of the vertebral body here. So a lot of debate again about the approach. Do we do a transthoracic approach here? Do we do a posterior spinal approach? Do we do a combined approach here? I unfortunately don't have a video for this, but basically we did a posterior spinal approach. We completed the facetectomy above and below here, and we were able to take this out. I won't call it en bloc, but we basically amputated the tumor at the T3 nerve root, took out the interspinal component, and then we were able to take the ribs down and take this all out from a posterior retropleural approach here. This is just a this is a 3D reconstruction that we have, just showing preoperatively. This helped us to plan it. This was completely extrapleural. This is just showing the biopsy tract here, planning the surgery. 3-level laminectomy, our troughs above and below, facetectomy, which was pretty much done for us already, as well as a pediculectomy above and below. And then we cut the ribs about 5 to 6 centimeters out laterally, and then again medially. This is actually a video where we actually had our thoracic surgeon come in with a thoracoscope for the ventral dissection of the tumor so that we did not poke through the pleura. This is actually the lung here. This is the aorta, the descending aorta over here. And what you'll see in this video is these are our pen fields dissecting the tumor away from the ventral part of the pleura. We really did not want to get through the pleura here. We were concerned if we had a CSF leak, it could be a bad complication if we had a CSF pleural fistula. So we did not take the tumor out through a thoracoscopic way, but we did use it to help us visualize dissecting the tumor out here. And again, this was an extradural tumor, but this is a schwannoma, and this is us delivering the tumor out in a posterior retropleural technique. This is us with the illumination with the thoracoscope and not getting any type of pleural defect here. And this is us taking out the posterior mediastinal component on block here. We did instrument the patient a couple levels above and below, like I said, just because potentially destabilizing upper thoracic spine. Pedicle was completely eroded, and we took a facet above and below. And this shows a gross total resection, basically from a posterior only approach to taking this tumor out. We do think of ependymomas moving on. These are typically intramedullary type of tumors. We can see them in the extramedullary space. This is a young fellow that came to us. This was done at an outside facility where he had an en bloc resection of a coccygeal. This is an extraneural ependymoma. Unfortunately, he did have lymph node metastases from this. He moved regionally in the country, moved to Syracuse, New York. And he presented to us with further bowel and bladder dysfunction after he did have some improvement from the first surgery. And what we see here is that the entire sacral canal is filled up here. I don't have an operative video here, but we were able to take out this entire tumor, dorsal and ventral. You don't get to see this too often. This is the termination of the thecal sac. This is S1, S2, S3, and S4 nerve roots here. So this is just an interesting case of an extraneural ependymoma. We think of chordomas as a primary bone tumor. On rare occasion, we can actually see intradural chordomas. One of my orthopedic colleagues about 10 or 12 years ago had a case of a T12 chordoma. They attempted to unblock it. I suspect, though, that they may have gotten into the tumors. You can see here the tumor does come down to the superior part of the end plate of L1, and all they took was T12. And she did well for several years, but then she presented back to us with hardware failure. Ended up needing multiple revisions. On one of the previous revisions, my orthopedic colleague had told me that they had a very large CSF leak, and she came to us basically with a myelographic block, and he had a strong suspicion that the patient had an intradural disease, and he was in fact correct. So we took her to surgery. This was just about 4 to 6 weeks ago. This is rare. You don't see this too often, an intradural chordoma here. We're able to take this out. It wasn't too large, but I think one of her larger problems was that she actually had significant caudate equine tethering. As you could see, she did have postoperative radiation as well, and we were able to untether that. And again, there's no hope for a cure in this particular case. She actually had extra spinal
Dr.
disease
Galgano.
as well.
Dr.
But we were
Galgano.
at least able to get a post-operative CT myelogram on her and restore CSF flow after that.
Dr. Galgano.
Yes.
Excuse me, please. Would you please wind the talk for us, please? Because in 15 minutes we'll have the big
yes,
section.
absolutely. So I could be finished here. These were just the last couple of cases I was going to show of a few rare. This is a non-small cell cancer and a meningioma case that we did. But you know, for the sake of time, we'll take some questions now. If anyone has any questions. So thank you for listening.
Dr. Prasad, do you want to go ahead with the question of Nick, please? Thanks.
Yeah, very extensive talk, and it's the cases are really very interesting, but for want of time, we need to stop it here.
Oh, no worries at all. Thank you.
Yeah, very interesting cases, especially the sacral ones are really interesting. I had not thought of this varied presentations of intradural extramedullary tumors. Like, yeah, if I can ask a question about the extraforaminal component of neurofibroma, suppose it's quite big. Like, are there any times in which you would keep it away anyway if good decompression is done and if your access from posterior is has decompressed the neural components quite well? Like, would you consider not chasing the extraforaminal component?
Yeah, I think that's very reasonable in a patient that does not have neurofibromatosis. If they do have neurofibromatosis, like I said, I do worry a little bit that there's a, you know, it's not a large chance, but about a 5 to 10% chance that some of these tumors will develop into a malignant peripheral nerve sheath tumor. So I would try to be as aggressive as I could with it, trying to take these out on block if possible. If not, even if I get into the tumor, just trying to take out as much of it as I can. So even if it is extraforaminal completely and I have to get a surgical oncologist involved, I'm pretty aggressive with these. So I would still make a bold attempt. Even like these cases you see here, I didn't show these. These are schwannomas here, new cases in my clinic now, but I'm going to make an attempt with surgical oncology to take all of this out.
Thank you.
Great.
Thank
you very much.
Dr. Galgano, could you please put it on the chat side? And Dr. Galgano, if you would be kind enough to answer them.
Yeah, there are some more questions for Dr. Galgano. If you can please answer them in the chat box. It will be some interesting questions in the chat box. Thank you very much, Dr. Galgano.
Sure, thank you.
Very fascinating cases, I have to say. I have not come across many of them at all. Thank you very much.
Thank you.
Just two housekeeping things. One is that at the end of the 4th session, I will send you a feedback form, a link for a feedback form. When you complete it, then we will send you the certificate. Certificates might take 2 to 3 weeks to come, but that I will send you. They give you the link at the end of the 4th session. So you can stretch yourself for the next 10 or 13 minutes because we have got our lectures from Dr. Ed Benzel, Dr. Richard Fessler, and Dr. Kara Sedney. I mean, Dr. Benzel and Dr. Fessler, they are legends of the field, and usually you can just have them at one conference, a huge conference, to fill up a auditorium. So please rest yourself for 10 minutes and be treated to two legends. Thank you very much, everyone. See you in 10 minutes. Okay. Thank you. Thank you very much, Dr. Galano.
बाबा आपको कितने चाहिए? बाबा कितने पकड़े चाहिए? कितने?
Hello, Dr. Bensel. Thank you very much. Yeah. Hello, sir.
You bet. Are you waiting for me?
Just we have got 3 minutes. You're fine. You're
Okay.
fine. We are just going for a stretching of the legs.
Okay.
And then just listen to you talk. That's good.
Can I pull up my,
Yes, please. Thanks.
do I just hit share screen and
Yeah.
I'm going to stop the other screen?
Yes, please. Thanks. Dr. Benzel, Professor Miguel Ares will be chairing your session.
Okay.
Hi.
Hello,
Good afternoon.
how are you?
Fine, thanks. Thank you. Very happy to be here. Waiting to listen to your presentation.
Thank you. Can you see my, I don't know.
We see the screen.
You do. So
you have to click on the presentation, deformity, my journey.
So you can see that now.
Yeah.
Okay, we'll wait now.
Okay. Good. It's Professor Ares, do you want to introduce Dr. Benzel? It's 3 o'clock now.
That's okay. Good afternoon to everybody. First of all, Naren, congratulations for the wonderful initiative on this course on spine. Very, very interesting topics. And I think that the session is going to be great. And our first speaker is Professor Benzel from Cleveland Clinic. I don't think Professor Benzel needs any introduction because he's very well known by many things, not only in the field of spine, but also in the academic field. And he's the editor-in-chief of the very well-known and very much appreciated journal World Neurosurgery. I'm happy to contribute reviewing. And I think that his presentation is very much expected, as this presentation is going to deal with one of the big issues in cervical spine as myelopathy and deformity is. So, Professor Benzel, if you want to add something, Naren, if not, I think we are going to start with the presentation of Professor Benzel.
Thanks.
Okay, thank you very much, Miguel. That was way too kind of you. I am going to describe today my journey and how I came upon different things as components of the overall management strategy that I use for managing patients with cervical spondylotic myelopathy and deformity. I'm going to begin with some basic biomechanics, and then I am going to proceed on my journey. Let's start with the biomechanics of spinal column failure. Fundamentally, we must know this equation. Bending moment is the product of the force times the distance. So if we apply a load or a force at a distance d from the axis of rotation, which we call the instantaneous axis of rotation, it creates a bending moment, which is the product of this force times this distance. And this creates a increased stress or concentration of stresses ventrally, which initiates failure, which is propagated dorsally. All points ventral to the IAR come closer together.
Excuse me, please, Dr. Ben, sir, beg your pardon. You couldn't start the PowerPoint presentation for us, please. We are only seeing the, we are not seeing the slides. If you open the PowerPoint file, is it open already?
It is open. Let's go back. Let me see the share button again.
Yeah. You can see your window.
You can. So we
can see the window.
You see the opening slide right here, CSM and deformity, my journey.
We see it as a file in the Finder window.
Okay. Now, what if I hit this? Do you see it? The slide?
Not yet. No.
Okay.
We can start again with the share and.
Yeah. Let me. What do you want me to do then?
If you stop share and then restart it, then.
I can't see the share button at the bottom, unfortunately.
Okay, let me see. You should be able to.
Aha, it's at the top. Start share.
So if you probably stop share and then restart, and then you can find where the PowerPoint window is. That's it. We got it. Great. Thank you. Great.
Now I need to. Okay, so I'll start all over again.
Please, thanks. Thank you.
I'm gonna. You can see my arrow moving around and everything, correct?
No. If you go to the top where it says annotations, maybe you might see a arrow movement.
You can see it.
An arrow is moving, sir.
Is arrow moving for you? Is it okay?
You can see it.
Yep.
Okay.
Okay. I am so sorry.
That's okay.
I'm going to address myelopathy and deformity, and I'm going to describe my journey. I'm going to begin with biomechanics. You see the biomechanics slide, correct?
Yes.
Okay. Moment arm equals force times distance. A force applied at a distance from the IAR, instantaneous axis of rotation, creates a bending moment that is the product of the force times the distance. This causes a concentration of stresses ventrally in this case, which initiates failure, which propagates dorsally. All points ventral to the IAR come closer together, and all points dorsal become farther apart. I'm going to begin this journey, but just simply describing some biomechanics of spinal instrumentation, and I already described failure, but we use spinal implants to prevent or treat deformity. And we use these moment arms to do this. And Archimedes said, give me a lever arm long enough and a fulcrum on which to place it, and I shall move the world, which is theoretically true. We think, and as we should, along the lines of the Cartesian coordinate system, and consider rotations and movements along or about each axis of this system. So in this case, with the cartoon that I've already showed once, the axis of rotation is right at the instantaneous axis of rotation point. So there are 6 forms of ability, 6 mechanisms by which we can resist motion. In the upper left, and again, you can see my arrow. Is that correct?
Yes, sir.
Yeah.
Okay. We can apply a force in the interbody region, and if it's in line with the with the axis of rotation, it does not apply a bending moment. If it would be dorsal to it, it would apply a bending moment, which would initiate flexion or kyphosis. The second type is that of three-point bending. This is a very important strategy, as I will allude to later, where this load here plus this load equals the load at the fulcrum. This is the moment arm and fulcrum that Archimedes was referring to. We can apply dorsal compression to the spine. We call this a tension band fixator. That would be applied by perhaps cerclage wires or a clamp. And then there are three types of cantilevers. A fixed moment arm cantilever beam is a beam that is rigidly affixed to an immobile object. This would be like a rigid screw affixed to a rod or a plate. A cantilever beam, by the way, is a beam that is affixed to an immobile object at one end only. So if it's rigidly affixed, it's called a fixed moment arm cantilever beam. If it's affixed by a hinge or a screw that could toggle, we'll call it a non-fixed moment arm cantilever beam. And if we apply a bending moment by virtue of Shantz type screws, or say with a cast bar plate, or cast bar pins, we would call that an applied bending moment. The spine can fail as well. If we apply pressure in the middle of a tin can, the can bends, it doinks in. If we apply pressure with our thumb to the edge, it's very rigid. This is called the boundary effect. And henceforth, we tend to put devices in the inner body region, which are located more towards the perimeter as opposed to the middle, because if they're in the middle of the end plate, they tend to subside. Implants fracture. This is a fixed moment arm cantilever beam that fractured at the screw plate junction. This is another one that fractured near the tip. Why did this happen? This is related to stress. When an implant fractures, it always fractures at the point of maximum stress application. Let's think about this. Let's look at the strength of the object, which is described as the section modulus. And for a rod or a screw, the inner diameter of a screw is proportional to the third power of the diameter. This is stress. Remember, all implants, when they fracture at the point where this is the maximum, and stress is equal to the bending moment over the strength. So this plate fractured at a weak point, if you will. The section modulus at this point is very small, and the bending moment is relatively large. And henceforth, when it fractures at the with an application of three-point bending forces, which we've already discussed. It fractures at the point of maximum stress. So why does this screw fracture here and this screw fracture near its tip? So let's start with the first screw. That screw is a fixed inner diameter screw. And so if we look at the force applied to the screw that is rigidly affixed to a plate, we see that the bending moment, the numerator of the stress equation, increases linearly as we pass along the screw and is maximum here. The denominator of the screw, the section modulus, stays the same all the way across. And so the stress increases linearly as we pass along the screw, and it is maximum at its base, hence the screw fracturing at its base. So why does this screw fracture near its tip? Well, this is a tapered inner diameter screw. The bending moment increases linearly as we pass along the screw. So the bending moment in this case is maximum, just like with the fixed inner diameter screw at the base. But the denominator now is going to increase exponentially because it's proportional to the third power of the diameter of the screw. So the numerator is increasing linearly, the denominator increasing exponentially, and we see this type of a stress equation where the stress is maximum near the tip of the screw. Now we see fractures in this region very infrequently, and I've only seen the one that I've shown you here, and that is because these types of screws are so powerfully strong that they rarely fracture. Somehow a blue line appeared on my screen. I'm not sure. That's not me. Regardless, with a screw that can toggle, it allows subsidence of the plate. So the screw can windshield wiper through the bone. That's not necessarily a good thing. And it can obstruct sometimes the fusion interface with the interbody strut. This subsided, and actually the bone, this probably allowed the bone to heal. And although this is not a beautiful result, because the plate extended over the next adjacent disc space, a solid fusion with preservation of alignment occurred. This case is an extraordinarily interesting case because about half the screws fractured or backed out. And at the same time, this patient achieved a solid fusion at every level. And you can say, well, I thought that when we see screw or plate fracture, we usually have a pseudoarthrosis. And although that may be the case, this was a mid-generation Caspar plate. And so it had slots and holes for the screws, and this plate could subside through along the spine, and 3-point bending forces as it was subsiding are applied to the screws, which creates maximum stress in the middle and can cause fracture of the screw somewhere in the middle of the screw. But let's look more closely at this plate. This plate had slots on one side paired with holes on the other side. Slot, holes, slot, holes. So all the screws that were in a slot maintained their position and actually functioned as they were intended to, and allowed the spine to subside along the axis defined by the surgeon, or the curvature defined by the surgeon by the contouring of the plate. But the screws that were in holes either fractured or backed out because of the stresses that occurred as the plate subsided. And so this is a good illustration of the creation of bone healing enhancing forces by allowing the bone to see compression. Compression causes a positive charge over the surface of the bone, which increases osteoblastic activity, which increases the chance of fusion. And this is, we don't really think of it this way, but this is why we want bone to see in the interbody region. We want bone to see compression because it will heal better. This is basically Wolff's law. Here, this is a good example of subsidence causing a fracture of a screw in the middle of the screw, which is the result of the application of 3-point bending forces. Implants function differently under different loading conditions. I'm going to ask a rhetorical question here. Does anybody know, or can you think of a ventral compression implant? And the answer is not, we don't routinely think of it that way, but let's look at this situation. We know we can put a clamp on dorsally onto the spine and result in compression of the spine. But is there a device that allows us to apply ventral compression? So here's a device that might apply dorsal compression, a cerclage wire or a clamp. Let's think about what we do when we put in a plate like after a cervical discectomy. We know it's a cantilever beam, and so it is a cantilever. We know that it actually is neutral when it's put in, more or less, but when the patient stands, it resists compression. And so therefore, it is a distraction device also. But what about when the patient extends his or her neck? It's actually holding the spine in position and actually resisting distraction, and henceforth is causing compression. So if we don't think of all the different ways that this device is going to be loaded, we may see failure because we performed a procedure or exposed the implant to forces that were not intended. So this device, when placed, can function as it does function as a cantilever, a distraction device in certain circumstances, and as a compression device in other circumstances. So these are the loading modes that we use. And this is, we want to use as many of them as possible. So we want to use a distraction device, tension band fixation, 3-point bending, and cantilever. What is missing of those 4 types of fixation here? Well, there's no intermediate point of fixation, so it's missing 3-point bending forces, and they cannot be applied with this device. So we know that this long bridging implant has a high incidence of failure, and we say, well, why does it fail? Is it because it's not good at resisting axial loads? Well, no, it's fairly good at resisting axial loads, but what it's poor at is resisting translation and rotation. And so what happens with translation and rotation with the application of this long bending, long moment arm and significant moments applied, we see degradation of the screw bone interface and ultimately failure. Now, a way to prevent that is to have native bone leaving a vertebral body and in the middle, and say doing a C5 or a C4 and C6 corpectomy, and having a fusion going from C3 to 5 and 5 to 7. We have this intermediate point of fixation, and the whole construct moves together, thus resisting failure. So this is a mode of failure that is commonly seen with long bridging implants. And this could have been helped and or prevented potentially by using an intermediate point of fixation into the native bone. Of course, we could do a dorsal operation as well and bolster it to help minimize the chance of failure, but that's 2 operations. And as you will see in a bit, we lose the opportunity to have an intermediate point of fixation, which helps us reduce deformities with the cervical spine. So here we are. I'm going to describe cases that I took care of over a 2-decade period. And we're going to just think about how to apply some of these biomechanical forces and principles to spine. Cervical spinalotic myelopathy is a result of encroachment and tethering and repetitive trauma. So oftentimes, I'm sure most of us have observed that if we just stop the trauma, stop the motion, myelopathy will improve. Each of these people has a spine deformity. They have a fixed kyphosis and of the cervical spine, and they have some other things going on, and they're complaining about 2 things. The first is the kyphosis trapezius sign. We see the trapezius muscle is hypertrophied here, and it is reflexively trying to extend the neck. Now, the trapezius muscle is an accessory muscle of neck extension, but it is not positioned well to extend the neck very effectively. So if the patient has, for whatever reason, weakened erector spinae muscles or has a fixed cervical kyphosis, the trapezius muscle is reflexively activated and goes into, I guess, what we might call a spasm, and it becomes quite evident and sore, and they develop a myofascial pain syndrome on top of all the other problems that they have, and we call that the kyphosis trapezius sign. But the patients also complain of back pain. Almost universally, patients with significant cervical kyphosis present with also an associated complaint of back pain. This unfortunate lady had a fusion from occiput to the thoracic spine for reasons that were unclear to us. And she presents complaining of the kyphosis trapezius sign. You can see her muscles being tightened here, but look at what she's doing. In order to look forward, she has to extend backward. Look at if we drop a plumb line from C7 down, it falls way behind the L5-S1 disc space. And henceforth, she's leaning backwards and is loading her facets eccentrically and her disc eccentrically, which results in a mechanical back pain of sorts. Here's another patient with that kyphosis trapezius sign, leaning way backwards just to see forward. And here's her cervical spine pathology. There are many non-operative strategies. They involve basically, though, postural, trying to sleep without a pillow or extending the neck as much as possible. This poor soul with ankylosing spondylitis wasn't treated early enough, and he probably used a lot of pillows because it made him, when he slept, because it made him more comfortable. But this caused his neck to fuse with his ankylosing spondylitis in a progressive kyphotic deformity. We can also apply strengthening to the spine by using various muscle strengthening exercises, core strengthening exercises. Those that work on extension are the most effective, like this situation. Now, often these patients are too fragile to undergo a big operation. And although I haven't seen actual correction of deformity with these strategies, I have seen multiple patients improve clinically from a pain perspective by performing core strengthening and flexibility exercises. So surgical strategies, Badhiwala, who's spearheaded multiple clinical trials, has spearheaded this particular trial, which is a cervical spondylotic myelopathy trial, looking at ventral versus dorsal approaches and efficacy. And it turns out that both ventral and dorsal approaches are very effective at treating the myelopathy. But what we then see is a big difference, however, in the health-related quality of life metrics that are seen postoperatively. Patients that have less of a sagittal vertical axis compared to this sagittal vertical axis have a much better health-related quality of life metric profile. So they complain basically of less neck pain. So one of our goals, whether we use a dorsal approach or a ventral approach, should be to establish as normal of an alignment as possible. So we should always apply heuristics, which are rules of thumb. I'm going to just go over one here that I think is deserving of close scrutiny, and that is, if you or I or any surgeon sees evidence of success, look for evidence of failure. You could look at this patient and say, her myelopathy improved and be very happy with her results, but she's not happy. Yes, her myelopathy improved, and we must be very careful in operating on patients with cervical myelopathy and making sure that the patient and the surgeon's goals and expectations are aligned. We think oftentimes we got to fix this myelopathy, and they're thinking, all I want is my neck pain gone. So here she is pre-op with flexion and extension views. This isn't bad extension, and if we could get her into this position, that would be pretty good, but that's not what I did. I misfired here. I didn't work hard enough to get her into an extended posture or a lordotic posture, and henceforth, I left her with a straightened spine and a chronic neck pain problem. The bad is on me there. So there are ways intraoperatively of doing this. What I really do predominantly is just multiple times during the procedure, break scrub and rotate the Mayfield head holder back to try to get more and more extension. And it takes patience to correct cervical deformities. This is the bivector technique of Dan Rue from Columbia University in New York. He uses Gardner-Wells tongs and has 2 ropes coming off the spine that go to weights. And when he is getting ready to correct the deformity, he pulls on this upper rope when under normal conditions might just use this lower rope. So he's got a fail safe here in case these pull out. I have a problem with this because the spine bounces around as you're doing your decompressions, et cetera. And I live in fear of the tongs pulling out of the skull because, over a long case. So I tried it a couple of times. I was not happy with it, but it's worthy of consideration because in others' hands, it may be worthwhile. Here's another picture. So we should focus on deformity. It decreases neck pain. I've already shown you a case where neck pain is caused by creating a deformity. It more effectively treats myelopathy, decreases end fusion degenerative changes, and improves both short and long-term success. We can attack the patient from a ventral or a dorsal or a combined approach. Bottom line, it's all about leverage. We can apply leverage with an applied bending moment. I mentioned this earlier. This is an applied bending moment device in a sense. We can create extension by manipulating the cast bar pins in this cervical case. We can also correct deformity by bringing bone to the implant. I have already referred to the importance of 3-point bending fixation in correcting deformity and in preventing failure. And in this case, we allow the spine to be brought to the contour of the implant by sequentially tightening screws and allowing the intermediate vertebral body to be brought to the implant. Let's just say this is C3, C5, C7. And we have to be careful that we don't put too much stress on the screws and we don't ask too much of this correction, deformity correction strategy. So here's a picture of a kyphosis, a close-up of that, and then sequentially tightening screws and correcting the kyphosis. It might look something like this post-op. We can also use gravity intraoperatively. Remember I said it takes patience. Gravity of the head, which weighs about 10 pounds, involves the phenomenon of viscoelasticity. Viscoelasticity is the phenomenon whereby gradual deformation occurs with the application of a constant load. So let's look at that. Here's a patient who's had multiple ventral and dorsal operations and has a lot of neck pain and a progressive myelopathy. We can see that there's been laminectomies, fusions, and it looks like some instability at this joint. Here we see a MRI, and at no point along this course of the spinal cord is there a loss of subarachnoid space as T2 signal, T2 CSF signal. Yet there is at the upper end here a signal change in the spinal cord, and the patient is myelopathic. So I took care of this patient over 20 years ago, and I said, my knowledge accumulated over time. I knew we could fix her ventrally because the facets weren't ankylosed, as we can see here. And when we put her in extension, we could see this level and a couple of other levels above extend. And so we said, let's do this from a ventral approach. We'll leave this fusion mass intact. So we put a roll under the shoulders and a donut under the head, and we start doing our operation, relaxing the spine by doing discectomies, etc. And then we take the donut from beneath the patient's head. So now the head is gradually extending, and it will, so we are essentially applying the phenomenon of viscoelasticity by applying a force to the spine by virtue of the weight of the head leaning backwards, and it will gradually, over maybe a period of 15 minutes to 30 minutes, help straighten the spine and help us become more effective at what we do. And we were able then to bring the bone to the implant, use trapezoidal spacers, which I'll show in a bit, and intermediate points of fixation, and correct her to approximately a 5-degree lordosis from a 15-degree kyphosis. And you say, well, that's not perfect, and it isn't perfect, but sometimes we must settle for good enough rather than taking excessive risks to to get that last amount of perfection. All this is about leverage. In the prone position, I must adjust the head holder over and over again, and if I'm not meticulous about it, I end up with this problem that I've already alluded to. But fixation follows, and here we are with a pretty good construct. And again, we could have used a posterior fixation and gotten good fixation, but we would have lost the ability to bring the bone to the implant, which was a critical part of the deformity correction in this particular patient if we'd done multiple level corpectomies. Again, bringing the bone to the implant is a critical component of the toolbox that we have for managing cervical deformity. Interestingly, post-op, her signal change disappeared, and her myelopathy, by the way, began improving right away. So remember, we didn't even have compression here, and yet she has a signal change there. And so, and keep in mind, this is 2 decades ago. So things became clearer to me as time passes. So I thought about this case a lot. Then not too much later, a patient was referred to me from Puerto Rico. He had previously had a laminectomy. He's a 68-year-old gentleman who previously had a laminectomy 10 years before for myelopathy, and he improved, and now his myelopathy was progressing again, and this is his MRI. So he was referred to me to address this problem. Is this a neurodegenerative disorder, or what is going on? So we must remember, and as was becoming clear to me, CSM, cervical spinal myelopathy, is a manifestation of repetitive trauma and tethering and distraction. So he could not get into extension, but he could flex at every level. His facet joints, therefore, were mobile. They were just had spurs in them that didn't allow him to go into full extension. So we said, let's get a flexion extension MRI. Here's his flexion MRI. So, this was an aha moment for me. This is one of the first dynamic MRIs that I'd ever gotten. And it became quite evident to me that an imaging study is basically a biopsy of a point in time. So oftentimes we may want to see what the spine looks like or the spinal cord looks like in other positions. And we have a protocol when we order a dynamic MRI that it goes to a specific scanner where there's a wider portal so the patient can be flexed. The techs understand the potential risky nature of putting a patient into kyphosis. And so we've not had any problems, but we've done it in a proactive manner. So here's neutral and kyphosis. So we knew we could correct him dorsally because each facet joint was not ankylosed. And as we can see here, so we did facet osteotomies and were able to get him into nice extension. And here we see the post-operative image, and we said, this is great. We've done a great job. Again, another heuristic. Every time you think you've done a great job, remember there could be some other problem. Look for causes of failure. And so what does he do? He kyphoses at C2-3. So what we learned from this particular case is that, first of all, the C2-3 facet joints were probably injured with the 2 operations he's had. And we did not really achieve a good alignment here because we then began focusing on what we call the C2-3 angle. The C2-3 angle in most normal people is horizontal to the floor in the standing position. This is not. And so what I have begun doing is hardly hesitating to take the instrumentation to C2. Fixation is better at C2. The patient loses very little motion by taking the implant one level further, and it can take this propensity to kyphose at the C2-3 junction out of the picture. So he was operated on by his original surgeon in Puerto Rico, and it's really difficult to get a correction with a facet osteotomy at C2-3, but so he fused him in this position, and actually the patient was relatively happy with this. I was able to subsequently see him, and he was very happy with his course with minimal pain. Okay, so the next patient that came in probably 15 years ago was this patient that had a traumatic C7T1 disc herniation, and he was treated with this operation. Because he had neck pain, this implant was taken out, but he had a kyphosis and a fusion in this position. So his MRI demonstrated no compression, and he did not have any signs of radiculopathy or myelopathy, but he does have the kyphosis trapezius sign, and obviously his back is extended, and he's complaining of back pain as well. So we took him to the operating room and determined that we really needed to do a front and a back operation. And we did facet osteotomies at each level, and then flipped him over and did used trapezoidal bone grafts. We cut our own from allograft fibula. We brought the bone to the implant. We used the viscoelasticity by allowing his head to drop further into extension. We brought the bone to the implant, and we got this correction. This is what he looks like post-op. Compare his kyphosis trapezius sign pre and post-op. There's a world of difference in this particular patient, and in basically all patients who have an adequate correction. Sometimes we should correct at another level. This patient has neurofibromatosis and dural ectasias and vascular ectasias, and has had several operations, and basically has an ear on shoulder type deformity. Look at the vertebral artery here. Here's a Halifax clamp that is in place. And here's another picture of her. We decided that this is no man's land here. She's got a solid fusion from C2 to the occiput, and there's no way that we're going to, excuse me, C2 to C1, and there's no way we're really going to be able to take this apart and fix it. So we said, we'll just deal with this. Here she is pre-op. And so we put her prone, and then after we got everything exposed, I went below the table and I twisted her head into a position that we wanted. So that she is looking straight down and her ear is not on her shoulder. And then we began doing osteotomies, and you can see how this popped open. This actually, with this particular level, when it opened with a pop. You could hear it. And so we got this correction, and then we put in screws, translaminar screws, if you will, or transfusion mass screws at C2, and this sort of an awkward looking construct. So there's two things here. Number one, if you're going to do this kind of a correction, make sure the patient understands that there could be a vertebral artery injury. with this. And that has to be taken into account when considering the indications for surgery. And number two, maybe explain to the patient pre-op that your construct may look a little funny, and this does look funny, but we as surgeons aren't in the business of making things look beautiful. We're in the business of using the anatomy that is dealt to us to correct deformity and prevent deformity and adequately decompress the spine. So here she is post-op, pre and post. Here she is now with, she has a little thoracic scoliosis, which could have contributed to this. But here she is pre-op with her CD surface rendering, and here she is post-op, and she was exceedingly happy. Sometimes we should do the cases in a staged manner. This is a lady who's had multiple ventral and dorsal operations and progressive myelopathy and a lot of neck pain. And for obvious reasons, here's her CT. Looks like there may be some instability up front. But for obvious reasons, we did not want to do a ventral approach on her. And so, and related to the fact that she had a kyphosis and a chin and neck bulge that would make access extraordinarily difficult. So we took her to the operating room and did a decompression. We did a laminectomy, and we could. This is in the days before intraoperative CT, and so we could only see down to about mid C2, and we felt that we probably didn't get a good deformity correction with our facet osteotomies. So we took her, closed the wound, put her in the ICU, left her in traction, not so much for traction purposes, but for reminding the caregivers that she had a potentially unstable neck. And we used viscoelasticity. We put rolls under her shoulder and allowed the neck to extend. Excuse me. And then about 5 days later, we got this CAT scan and we said, wow, this is great. We'll take this. So we took her to the operating room. We went from C2 with translaminar screws all the way down to the upper thoracic spine. Remember, she has a very heavy head and we wanted to make sure we get good fixation. And we then just hooked her system up. So this is the way she looked. Oh, this isn't going to work. Yeah, this is the way she looked pre-op. This is the way she looked at that intermediate CT. I'm going to stop this right here. This is a facet osteotomy. Always check your anatomy, MRI, and maybe CT to look for aberrant vertebral arteries and to make sure that there is no surprises. But the cervical nerve roots, except for the C2 nerve root, always pass ventral, the nerve roots pass dorsal to the vertebral artery. And so if you just follow the nerve root out, all the way out, you will be able to open up this book, if you will, so that when the patient extends his or her neck, then we see a closure of that. You also have to make sure that there's any spurs right in here, you get rid of those, because when you put the patient into extension, they could impinge upon the nerve root. And here she is post-operatively with her correction. And here she is post-op. So she lost some weight for a while, but then gained it back. So let's talk about the C2-3 angle. We looked at our patients who we corrected deformities on and look at the C2-3 angle. And we found that patients with a downward angle post-operatively had greater incidence of reoperation pseudoarthrosis, progressive kyphosis, adjacent segment degeneration, and disease. And it was very statistically significant. We also look at the C7T1 angle. And so I'd like to basically close now by a discussion in one more patient about utilizing these two angles and how they are utilized. The C2-3 angle we utilize intraoperatively to assess adequacy of deformity correction, and I will illustrate that. C7T1 angle, or the T1 slope, is used preoperatively to assess what we need to do for the patient. If you look at this case here, you could arguably say there's almost a lordosis of the cervical spine, but yet the patient has a huge SVA, sagittal vertical axis. The C2 body plumb line drops way ahead of the C7 body plumb line. So this problem is really an upper thoracic or cervical thoracic junction problem, and we need to think of what we're going to do for the patient based on this. So intraoperative utility. Here's the angle, a C2-3 angle. I'm just showing it with a CT so that you get an idea. Here's a measurement of the SVA, C2 to C7, and that's quite extensive in this particular patient. So here's a patient who's had a lumbar fusion and a bunch of cervical operations, and she's leaning forward, and so she's got a relatively significant SVA, and so her problem is in part related to her upper thoracic spine, and we see that she has a C2-3 angle that is pointed downward. So we intraoperatively do facet osteotomies at C7T1, T1, T2, and then another one at T2, T3. And with these facet osteotomies, we can get about 5 and sometimes 10 degrees per level. And I favor these operations over wedge osteotomies, which I think are much more dangerous and cause a focal extension of the spine, whereas this is a gradual extension of the spine at multiple segments. So we corrected her deformity, and we got this photograph. Well, actually, we got many MRIs, and we see that in the prone position, and we're going to make some assumptions here, that if we took this X-ray and held it upright, like over here, we can see the C2-3 angle. So before it was sloped down, now it's relatively horizontal. And so we use this to gauge our adequacy of deformity correction. And so we were able to correct her deformity. Now, this is one of the first patients that I actually used this strategy. I would tell you that post-op, you're going to lose a little. So if you really are concerned and you want to make sure that their post-op C2-3 angle is horizontal to the floor, I'd make this angle intraoperatively look upwards a bit. So here she is preoperatively, or excuse me, post-operatively, pre-op, post-op, pre-op, post-op, but look what she did here. Her C7 plumb line moved forward. This is probably artificially dorsal, because in order for her to look forward, most likely in the pre-op studies, she was bending her knees. And now she's no longer bending her knees because she's looking forward and the plumb line moves forward. But she had a very good result with this. So remember, we use C7T1 slope to determine what we're going to do, and we use the C2-3 angle to determine when we have done an adequate job. Adjacent segment disease, just one thought about that. There's a lot of talk with artificial cervical discs and preventing adjacent segment stresses, et cetera. And I'm not going to go into that in great detail, but actually artificial discs are usually ball and socket joints, and they increase stress at adjacent segments because of the load being transmitted without a cushion to adjacent segments or to the facet joints at that level. And my argument is that the major cause of deformity, or excuse me, of adjacent segment disease is not necessarily related to the stresses, to the motion, but related to the stresses placed at adjacent segments. And so there is a huge amount of literature, both biomechanical and clinical, both lumbar and cervical, looking at the notion that deformity accelerates adjacent segment changes. And so if we can correct this deformity at the C2-3 angle, we're going to reduce the chance that we're going to see adjacent segment disease. One last picture. These are two patients that have undergone a cervical discectomy and fusion. Both of them had their radiculopathy relieved. And I really don't know what ultimately happened to these patients, but this patient is left in a cervical lordosis, and we know that the adjacent segment disease is going to, or stresses are going to be less. This patient who's fused in a kyphosis, focal kyphosis, is probably going to be applying a lot greater stresses to the adjacent segment, and I would predict that this should most likely result in failure at the adjacent segments. I thank you very much.
Thank you, Professor Benson. Can you hear me?
Yes, I can.
Okay, so congratulations for this great talk. Thank you very much. I think that your journey has been very long, very interesting, and very fruitful for all of us. I think that, you know, what is in everybody's mind is the issue about anterior or posterior when dealing with myelopathy. I think you show very nice and very difficult cases going very much far beyond. I think I have a couple of questions. One of them related to anterior and posterior approach. First of all, about the issue of artificial disc. Is there any place in anterior approach in myelopathy for artificial disc, because of, you know, the discussion about whether or not at the midterm or long term the segment get fused or not? What is your opinion about, Professor?
Well, I would, first of all, I would not use an artificial disc for a deformity as a deformity correction tool. I'm sure others might. I see Rick Fessler's on. I'll pass the baton to him in a second. And my bias is against artificial discs, and that was obviously clear with what I just stated. But that does. But there are in different surgeons' hands, different tools can be effective, and so the long-term results of the studies that look at artificial discs look pretty good. But I think it's still just a tool, just like a spacer and a plate is. And the surgeon has to use his or her experience and interpret the literature, which is very cloudy, in my opinion. A lot of bias, commercial and surgeon bias and patient bias, et cetera, with clinical trials. Clinical trials for surgical strategies are very difficult to perform because they are bias laden. However, for deformity, I wouldn't use an artificial disc, but say for an ACDF, I see no problem with that. I just choose not to use it. Dr. Fessler, do you have an opinion there?
Even if you're just doing cervical deformity, even if you're not doing thoracolumbar, you're almost always going to be doing a posterior fusion, and that makes an artificial disc irrelevant. And there's no reason to use one.
But you use artificial discs in regular practice, not with necessarily deformity.
Correct. I use them very frequently.
Okay. See, here's two different opinions. One, I never use them, and Dr. Fessler uses them a lot. And, you know, you got to use what works in your hands.
Okay. Thank you very much. I have another second question regarding posterior approach. I think one of the fears when doing laminectomy with or without fusion is the issue of C5 deficit after decompression. Can you give some comments about that and the way of trying to avoid that, just preventively decompress foraminal, things like that? Can you make some comment, Professor?
So we are currently looking at patients and trying to randomize them to foraminotomy versus no foraminotomy for decompressive procedures from a dorsal approach. That looks to be early results look to be a little bit favorable for foraminotomy. And there are certain anatomical characteristics of foramina which may predispose to it. But I think the general thinking is that it's a stretch phenomenon, and that most patients who develop it, they develop it 12 to 36 hours post-op, heralded by shoulder pain and then weakness. And so you have to examine your patient right away to make sure they don't have a C5 palsy immediately after surgery, because if they subsequently develop one, I think you can basically manage that patient without reoperating on them. And most of the time they will recover. An important variable here, though, is in the consent or informed decision-making process. I always, when I'm involving the C4-5 foramina or level of decompression, I always inform the patient of the potential risk of a C5 palsy. So if it does happen, it's not a surprise. If you explain things in advance to patients, they understand, and that's part of the risk of surgery. But if they hear about a C5 palsy for the first time after they have one, it's very difficult for patients to be understanding. So I don't have any magic here, but I think if I was worried, I'd do a foraminotomy as a protective tool.
So, excuse me, you think that protective or preventive foraminotomy is useful? Should be done?
It looks like it is. It looks like it is. But I'm saying that it's just preliminary results, and I'm not sure if we've done a statistical analysis on the patients we have so far, but I'm guessing it's just a trend right now. So I'm not going to stick my neck out and say you should do a cervical foraminotomy every time you do if I was going to do a C3 through 6 laminoplasty, I usually don't do foraminotomies if the patient doesn't have a C5 deficit.
Right. Thank you very much for this wonderful presentation and asking this question on my side. Maybe Dr. Fessler or Dr. Prasadov, Dr. Galgano wants to make some question or some comment. I think the presentation has been superb.
Dr. Benzel, this is Mike Galgano from Upstate University in Syracuse. Excellent talk. I have a question to you about preventing distal junctional failure in some of these larger scale cervical thoracic deformities. Some of these patients that have very high T1 slopes, it's always tempting to pass the natural apex of their kyphosis, but then you end up potentially doing a fusion such as C2 to T8 or T9. Could you give us some tips and pearls as to how to prevent DJK and how you choose your lower instrumented vertebrae in some of these larger scale CT deformities?
So I rarely go below T3. Most often I stop at T2 and just get what I can get at C7, T1, and T1, T2. And so therefore, my strategy is to avoid by staying above. I haven't seen PJK or whatever, that'd be DJK, I guess, in these patients. But then again, I haven't pushed that envelope. What are your thoughts?
Well, I've had a few patients in my practice who very hyperkyphotic, and if I've ended at T2 or T3, which is proximal to their natural apex of kyphosis, I've had them maybe not too symptomatic, but on postoperative X-rays, they're kind of pitched more forward. So what I've done for some of these patients is gone a level past their natural apex of kyphosis, and it's anecdotal, but I've had less cases of distal junctional failure from that.
You're taking those down to T6, T7, T8?
Exactly. A few of them I have. Yeah. And I've actually had to revise a few that I've taken down to T2 or T3 that still have, distal kyphosis, distal to where I did my last instrumented vertebrae.
So it's interesting, just like Dr. Fessler and I disagree about what you should use as the spacer with after a cervical discectomy, we see different things in our practices. You know, I'm going to continue doing what I'm doing, and if I have this complication, then I will deal with it rather than expose. This would be my philosophy, rather than exposing the patient to a significantly longer construct. But you know. We take our own pulse more effectively than we think, and know our limits, and we see different things when we look at patients. And so I fully respect what you're doing, and I just don't see it. And maybe I'm just operating on a different patient population too.
Oh, thank you for those insights.
Thank you very much, Dr. Galvano. Thank you very much, Dr. Benzel. It was a fantastic lecture. Everyone has sending me how wonderful that they have learned and given new insight. You know, Dr. Benzel, in the chat box there are many questions for you. If you get time, should you get time, if you could please answer, we'll be all grateful. But obviously, if time is you have other engagements, fully understand it.
How do I answer them? Just go into the.
If you go to the chat box
okay,
on the bottom, and then you will see the questions that have been lined up for you in the chat area. I can.
Yeah, I see them. There's 28 questions. Wow. So.
You have all the weekend, Professor.
Yeah.
Good. Thanks. Thank you very much, Dr. Benzel, Mr. Professor Miguel. I'll say thank you to Dr. Benzel.
Okay, thank you.
Thank you, sir.
Thank you, Professor.
Next lecture is going to be a slight change in the schedule. It's going to be Dr. Fessler, and then it's going to be Dr. Kara Sedley. Dr. Fessler, I will just Dr. Fessler, you should be able to share your presentation now, Dr. Fessler.
I think I need to get out. How do I get out?
Or if you click stop share screen, then it should.
Okay, there we go.
Yeah, thank you.
All right, good day, everyone. Good morning, good afternoon, good evening, depending upon where you are. I hope everyone can see my screen now. Naren, can you see my screen?
Yes, absolutely.
Great. We're having a rainy, cold day in Chicago, so if you're not anywhere close to here, you're probably having a much better weather than we are. Ed, you maybe not.
Degrees and sunny, but tomorrow we get your weather a day later in Cleveland.
Sorry. Sunny day.
So I'm going to blame our weather tomorrow on you.
I accept responsibility.
Naren, I lost the chat room now.
No, not to worry. I'll get it to you, sir.
Okay. Thank you.
Yes.
All right. So this morning or today, we're going to talk about various treatments for surgical thoracic disc disease. There's an interesting history of thoracic disc disease. The first reported case of a spinal cord injury from what turned out to be a thoracic disc herniation was at Guy's Hospital, in their Guy's Hospital report in 1838, so nearly 200 years ago. At that time, they were calling these enchondromata, chondromata, or echondromata, all of which refer to benign tumors that originate from cartilage. So the original thought was that thoracic discs were actually tumors. The first two cases that they started thinking that this, in fact, was cartilaginous disc fragments was from Dandy in 1929, 100 years later. He described loose cartilaginous fragments which were protruding extradurally into the spinal canal. So after seeing that, Mixter and Barr reevaluated their series that had been called tumors and reclassified 19 of them as disc herniations, and 4 of those were in the thoracic spine. So the first report of a treatment of a thoracic disc herniation was also by Mixter and Barr, and they did laminectomy with excision of the disc herniation. Now, they did 3 cases. 2 of them were paralyzed and 1 died, and 1 they did not operate on, and that patient also died. So a typical patient is about 50 years old, male or female. They usually come with thoracic spine pain for about a year. Frequently, it radiates partially around the torso, and that's what helps us localize the level. They often describe progressive gait difficulty, urinary urgency, and occasionally a history of trauma. If you take autopsies, about 7 people per 100 will have a herniated disc in their thoracic spine at autopsy. But clinical symptoms vary somewhere between 1 in 1,000 and 1 in 1,000,000 of actual disc herniations in the thoracic spine. The acute presentations are presenting within a day or a month with an acute cord or radicular symptom. This will usually be from a soft disc herniation, and with prompt treatment, these patients can do very well. A more chronic degenerative presentation, though, is a very prolonged history, usually no history of trauma. This can either be a soft or a hard disc. We've found over time that posterior approaches to these have a relatively poor outcome. Anterior approaches give you a better outcome. Localizing signs and symptoms, appropriately recognized early on, can lead to a rapid diagnosis. Unfortunately, they are often misdiagnosed, which is our first complication of treating thoracic discs. There we go. So what are some of our signs and symptoms? Well, if it's a high thoracic disc at C7T1, often this is diagnosed as a myocardial infarction. At T12, it's been diagnosed as angina, dissection, or even a pancreatic tumor. Those patients frequently are presenting with Horner's syndrome. A little bit lower down, it's frequently presents with a Brown-Séquard syndrome or an anterior spinal artery syndrome, unfortunately, which is irreversible. And if they come with radiculopathy, differential diagnosis for that is renal colic, cholecystitis, colitis, intercostal neuritis, or costochondritis. What if they come to you with alternating symptoms where sometimes they're symptomatic, sometimes they're not? Well, we have to consider demyelinating disease, particularly MS in those patients. And it can also be cervical stenosis presenting in that manner. Patient comes to you with symptoms and no pain. We have to consider primary motor neuron disease, myopathy, muscular dystrophy, or motor neuropathies. So the differential diagnosis for thoracic disc herniation is extensive and is level specific, but it has become much easier to diagnose with the advent of MRI than it was prior to MRI. So how do we evaluate them radiographically? Plain X-rays are not very useful. The most useful localizing sign is that somewhere between 30 to 70% will have calcification of the disc space. Localized kyphosis, osteophytes, and disc space height are not very diagnostic and very hard to demonstrate in thoracic plain X-rays. With a myelogram and a CT, we find that 12% of them are intradural, but as many, somewhere between 11 and 13%, are completely asymptomatic. In MRI, about the same amount of patients will have evidence of a thoracic disc herniation and be completely asymptomatic. And this is certainly the most frequent thing I see in patients who are coming in, for example, with symptoms of cervical myelopathy and also get a thoracic MRI, and they've got thoracic herniated discs, but are completely asymptomatic. They neither have back pain from it, nor do they have radiculopathy. So looking at some of the bigger series of publications that are presented with many patients, in my personal series, my patients were presenting with durations of symptoms somewhere between 3 months and 18 years. Stillerman and Weiss had 60% evidence of weakness. Mayman reported 43, I reported 41. Local pain, again, 60% for Mayman, almost 80%, for Stillerman, almost 80% for Mayman, and almost 90% in my particular series. I had an equal incidence of sensory loss, as did Mayman. Stillerman's series had a much lower presentation of sensory loss at 18%. And in terms of bowel and bladder, 18% for Stillerman, 43% for Mayman, 47% for me. I think the variation in presentations here may be a presentation of the type of patients that we were seeing. Obviously, I was seeing some fairly chronic patients. And I also had a very high incidence of radicular pain compared to 35% and 16% for Stillerman and Weiss. Clearly, there are many approaches to treating thoracic disc disease. First approach was laminectomy, followed by transpedicular. Stillerman described a transfacet pedicle sparing approach, costotransversectomy, lateral extracavitary, an anterolateral thoracotomy, thoracoscopy, endoscopic costotransversectomy, and endoscopic transpedicular. So in a laminectomy, everybody's very familiar with that. We just remove the lamina and the facet. If all we're doing is trying to create more space, that's a reasonable thing to do. As Mixter and Barr demonstrated, actually going after thoracic disc with just a laminectomy has an extremely high complication rate and is actually, in my opinion, a contraindicated operation. If we look at the, let's go back. If we look at the various people who have done this over the years, Perot and Monroe in 62 had 2 patients. This is, anterolateral thoracotomy has a much lower, here we go. This is the one I wanted. The people who have used laminectomy over the years, we talked about Mixter and Barr, 2 paralyses and 1 death. Hawk in 36, 4 patients, 2 paralyses, 2 deaths. Love and Kiefer, 17 patients, 4 paralyses. Mueller, 4 patients, 3 paralyses, 1 death. It's pretty clear as you look at all of these, the extremely high major complication rate and morbidity in doing thoracic laminectomies and going after the disc. The next operation, though, to get around this was the transthoracic, the anterolateral transthoracic approach, in which you would do a thoracotomy, come in and remove the head of the rib, part of the vertebral body, part of the pedicle, to expose the entire anterior and lateral surface, and thereby getting a really nice decompression. And the results of that operation immediately had a huge impact on major complications and on morbidity. Perot and Monroe and Ransohoff were the first to describe this. No paralyses, no deaths. Really only 1 paralysis, and that was in 48 patients in the Stillerman publication. So this really changed the approach for particularly central thoracic disc herniations and had a huge impact on mortality and morbidity. But a lot of disc herniations are soft and lateral, and to do a large thoracotomy seemed to be too big of an operation. And that's when the transpedicular operation came, when you do a hemilaminectomy, a partial removal of the transverse process and removal of the pedicle to then be able to get into the disc, remove the osteophytes, remove the disc, and then reach underneath the spinal cord to get the central and more the lateral components of the disc herniation. Now, Charlie Stillerman felt that it wasn't necessary to remove the pedicle, and he described a transfacet pedicle sparing, which gets you right down onto the disc space, but doesn't make you remove the pedicles. Very often you end up doing a partial pediculectomy in this operation just to give you more room so that you can reach up higher underneath the spinal cord and down lower underneath the spinal cord to get the osteophytes that are associated with the disc herniation. If you have a more central herniated disc, that transfacet or transpedicular operation probably won't get you medial enough to be able to do a safe, complete discectomy. So for that operation, the costotransversectomy was developed. And in that, you remove the pedicle, the transverse process, and the medial portion and insertion of the rib head, which then gives you a very nice access to the lateral portion of the spinal cord, at least half of the circumference of the ventral surface of the spinal cord, and it gives you quite a bit of room to work to get a more centrally located disc herniation. Now, if you've got a very centrally located disc herniation that is either intradural or at least calcified, then an even more aggressive operation would be indicated, and that's called the lateral extracavitary. And in that operation, you're going to do the same thing. You're going to do a partial hemilaminectomy. You're going to remove the transverse process, the rib head insertion, but also much more of the rib so that you're not coming in at this kind of an angle, but you're really coming in almost perpendicular to the dura. That gets you all the way over to the other side. The only thing you can't see is this little bit right here. And by reaching underneath, you can usually decompress that without direct vision. But it gives you an excellent view of the entire lateral surface of the spinal cord. And you can see how aggressive of a discectomy you can do to decompress virtually the entire ventral surface. Now, after that operation was developed, thoracoscopy came along. That evolved out of doing laparoscopy and thoracic surgeons doing thoracoscopy. And we then modified that to be able to do thoracic discs. And we were usually doing that through either 3 or 4 portals, giving you one for the camera, one for a retractor, and then 1 or 2 working channels. It gave you excellent visualization of the lateral aspect of the vertebral bodies and the insertion of the rib heads. And then once you had that exposure, you could incise the disc, do an aggressive discectomy, sometimes do a fusion through that if you needed to. So if we compare the mortality and morbidity of these various procedures, we've already talked about the extremely high paralysis rate with laminectomy and high mortality rate. With all of the other procedures, those were essentially eliminated. And then we can start talking about morbidities. We never have talked about morbidity here because they were all paralyzed or dead. So now that they're not, well, then what are the other complications that we see with the transpedicular approach, the costotransversectomy, lateral extracavitary, anterolateral transthoracic, or thoracoscopy? Well, Danny Rosenthal was one of the pioneers and giants doing thoracoscopy. When he compared his results comparing morbidities with thoracoscopy versus the thoracotomy, he dropped intercostal neuralgia from 59% to 16%. Doing a standard costotransversectomy was about 20%. No subcutaneous emphysemas in these, but that was a problem. Doing with Rosenthal's series of 2%, not too bad. Wrong level surgery, costotransversectomy was 7%, thoracotomy none. Wrong level surgery was 4% in thoracoscopy. Retained discs 4%, 13% in this, and this is a less aggressive approach. So that's not too surprising. Decreased neurologic function 2% versus 7%. Atelectasis 7% in thoracoscopy, 33% in thoracotomy, 13% in costotransversectomy. Relatively equal pleural effusions. Chylothorax was higher in thoracotomy. Probably this is coming as we get closer to the insertions of the diaphragm. We didn't have any of those with either of these procedures. Relatively equal hemothorax, and thoracotomy had the highest infection rate. These are both very much smaller operations, so not too surprising. In my own series of doing thoracoscopies, I did 9 sympathectomies, 13 anterior releases for scoliosis, 28 discectomies, 4 vertebrectomies, 18 anterior fusions, and 2 anterior instrumentations. These are the levels that I did, most of them from T7-8 down to T12L1. Operative time took me about usually 4 to 5 hours, 250 cc's of blood loss, just 1 night of ICU, and that's because they had 1 night of a chest tube. Chest tube was about 200 cc's, and length of stay was about 5 days. That wasn't a whole lot less than lateral extracavitary or open thoracotomy. My sympathectomies were much shorter, much less blood loss, just 20, again, 1 night in because of the chest tube, a little bit less blood and much shorter length of stay. I had 2 complications in my series, one neurogenic pulmonary edema and one myocardial infarction that occurred 6 months following surgery. There were no neurologic injuries. But I wasn't totally satisfied with that operation. And by that time, I had been doing quite a bit of minimally invasive tubular surgery. And it seemed to me that there wasn't any reason why we had to do an open costotransversectomy or lateral extracavitary. There's no reason we couldn't do it through a tube. So we went into the cadaver laboratory and adapted our techniques to be able to do a thoracic discectomy through a tube. So the advantages were that it would give us a much smaller skin incision with minimal tissue disruption, minimal muscle injury. We could get excellent visualization, no intrathoracic dissection, and they didn't have to be fused. So after doing 5 human cadavers, we went down and converted this into doing our patients. And so this is a minimally invasive lateral extracavitary. The incision is 3 centimeters long, approximately 8 centimeters off midline, and then dilating down to the insertion of the transverse process in the rib head, removing the soft tissue over that area, and then removing the proximal portion of the transverse process. That allows us then to follow the rib head all the way down to its insertion and remove the rib and the rib head for approximately 8 centimeters, giving us essentially the same approach to the lateral aspect of the spinal cord as an open lateral extracavitary. Once the rib head is removed, then we expand the neuroforamen by removing the inferior portion of the superior pedicle and the superior portion of the inferior pedicle. Beginning to see the lateral aspect of the spinal cord there, just the dorsal part of it. So we're removing a little bit more soft tissue, a little bit more pedicle. Right down here, we're beginning to see the disc space. So here's the lateral aspect of the dura. And now it's becoming more clear. And the disc now is right down here. So here's the ventral part of the dura. And we've incised into the disc, going into the disc and removing the disc fragments. I'm creating a space in the disc now so that I can then reach underneath the ventral surface of the dura and push the fragment down into the disc before I remove it. So I can see it's quite a large fragment that we removed from this person. Confirm that we had a complete decompression. And then remove the tube. So the only closure is a couple of stitches in the fascia, some subcutaneous tissues under the skin, and then gluing the skin shut. All the muscle you can see completely stays intact. So at the time I put this lecture together, I had done 10 patients. Took about 2 hours per level, 113 cc's of blood loss. 8 out of 10 were done as outpatient. There were no complications. This was a police officer in whom I did 3 levels on. I did one from one side, 2 from the other side. And you can see the approach and how good of an exposure you can get of the lateral aspect of the dura with this technique. So the advantages of this technique are that it's relatively simple. It avoids all the vital interthoracic structures, directly decompresses the nerve root. It avoids fusion and its complications, and it prevents adjacent level sequelae. The disadvantage is it requires really intimate knowledge of the anatomy. It requires skill in working through a tube. So this would not be you would not want to do this as your first case. And it's still, even though it's a lateral extracavitary approach, you get a limited view of the ventral and particularly contralateral ventral dura. That video I showed you was on a defensive end for the University of Indiana, who then went on and being drafted, as I recall, by the Bengals and continued his football career. So conclusions are, the selection between the operation you choose to do should be made on the location of the herniation, the general health of the patient, and your experience at doing various operations. Problems are that most patients are not reported, and the diligence varies between reports, so we probably don't know the actual complication rates of many of these operations or how many patients were actually done with the various types of operations. And something that is a complication for one patient is not a complication for one physician, is not a complication for another physician. Thoracoscopy isn't done very much anymore. It turned out to be a relatively difficult operation technically for many patients, and the advantages did not really outweigh the technical hurdles you had to get over. The disadvantages of the transpendicular approach are that you get a very limited view of the center of the ventral portion of the disc, so it's limited to lateral disc herniations. The advantage, though, is that it's a very routine procedure. Only the spinal cord is at risk, and for a lateral soft disc herniation, it's really an excellent operation. Costotransversectomy, you still get poor visualization of the ventral cord. It's very poor for an intradural disc, and you get a limited view of a lateral. So this is limited also to lateral disc herniations. But the advantages are it's still quite an easy operation. There's minimal risk to the radicular arteries or veins. There's less risk to the spinal cord. And you get slightly better visualization of the ventral dura than you do with a transpendicular approach. The disadvantages of the anterolateral transthoracic approach are that it exposes all your interthoracic contents. And occasionally the vena cava will be directly where you have to operate. And I prefer to approach these from the aortic side if I can, because you can retract on the aorta with relative ease, but it's much harder to deal with the vena cava. It leads to longer hospitalizations and ICU stays. The approach to the cord is actually relatively blind, and intradural risk requires extensive vertebrectomy in order to be able to approach that. The advantages are, however, that you do get a complete exposure of the ventral cord eventually. Your anatomy is easily identifiable, and this is the operation that took us from extremely high mortality and morbidity rates to essentially zero. Lateral extracavitary is a larger operation. It exposes the radicular arteries and veins and possibly the aorta and vena cava, and you get poor visualization of this contralateral corner over here. But the advantages are you get an excellent exposure of most of the ventral spinal cord. There is no risk to intrapleural structures. You have less risk to the spinal cord. You approach the cord under complete visualization, and it can be used good. It's a good operation for intradural discs, and it's very easy to reconstruct your dura through this approach. The disadvantages of the thoracoscopic approach are it's a steep learning curve. Blood can obscure your visualization, and it really never quite achieved the results that we had hoped that it would. But on the other hand, there's decreased surgical pain, there's shorter ICU and hospital stay. You get excellent visualization of the intrathoracic contents, and you can expose the entire ventral spinal cord from this approach. Disadvantages of the endoscopic transversectomy: you have a restricted working space, potentially decreased light and visualization depending upon what system you're using, and there's a significant learning curve for the MIS technique, particularly when you're coming from a posterolateral approach rather than a directly lateral approach. But it's minimal skin incision. There's minimal to no muscle dissection. There's no need to remove the rib. You don't violate the intrapleural space, and you have relatively short hospital stays. At this point, I do most of my thoracic discs through a minimally invasive transfacet pedicle sparing approach. If I have to get centrally, or if I've got an intradural disc, I will do that through a minimally invasive lateral extracavitary. So thank you. I hope everyone has a great day. And if we have a few minutes, I'd be happy to answer any questions.
Thank you very much, Professor Fessler. I hope you can hear me.
I can, thank you.
Okay, thank you. Thank you for this wonderful talk. I think just dealing with, to me, with the most difficult topic in spine, that is thoracic disc. Thank you for this comprehensive overview of diagnosis and surgical possibilities. I have a couple of questions before the other colleagues want to make one. First of all, regarding indication for surgery, do you consider pure radiculopathy as indication for surgery? Not myelopathy, but radiculopathy? Do you think this could be an indication for surgery?
Yes, I do. In fact, radiculopathy, obviously myelopathy is an indication, but radiculopathy is a very good indication. But back pain is not a good indication. If a patient comes with the thoracic disc and has only back pain, I'm very hesitant to operate because that usually does not get better. Radiculopathy can be really disabling for these patients. It's lancinating shock-like pain radiating around their chest or abdomen, and those patients do wonderfully. With the minimally invasive transfacet procedure, it's an hour operation and it's an outpatient procedure.
That's okay. Thank you very much. I think there is another issue in everybody's mind when talking about surgery for thoracic disc, and it's the way to avoid the wrong level during the operation. What is your strategy?
That is so important in thoracic surgery, and you have to be absolutely rigid in your procedure. The way I avoid wrong level surgery is preoperatively, I make sure I have a chest x-ray so that I can count and confirm that they have 12 ribs. And I have lumbar spine x-rays so that I can confirm that they have 5 lumbar vertebrae and not 4 or 6. And I make sure I have a preoperative MRI in which I can count either from the sacrum or C2 to the actual level that has the herniation within the same cut, so that I know absolutely which level it's at. Then in surgery, you really have 2 options. If you want to use image guidance, that can be a way to help you positively identify the level. I personally use fluoroscopy, and I count mostly from the sacrum with continuous fluoroscopy, moving the fluoroscope or the marker that I'm using independently. I never move them together. I will, for example, I'll put my marker on L3, I'll turn on the fluoroscope, I can see the sacrum, and then I'll move the fluoroscope up so that I know I'm on L3, and then I'll move my marker up to the next level, and I count my way up to the appropriate disc. Then, when I'm at the appropriate disc, I will make my incision, do my dilation, and then once my dilator is in place, I repeat that process to confirm that I dilated to the correct level.
Thank you very much. A short question before the other colleagues start to ask questions to you. Regarding your beautiful approach, tubular approach, first of all, can the microscope be used instead of endoscope? And second, you mentioned one of the limitations as intradural disc. Is calcified disc another limitation, or you can cope with it?
You know, through a tube, it's harder to cope with it. If you use an expandable tube, that helps a lot. But to do that, you might have to remove 2 ribs rather than 1, the one below and the one at the level. Yeah, absolutely, you can use a microscope. There's
Right.
no reason not to.
Thank you. I think there are several questions, one of them from Dr. Galgano, and maybe Professor Sileli or Professor Benzel. Please go ahead.
Yeah, can I ask something?
Sure.
I thank you for very nice lecture, actually, Richard.
Hi, nice to see you.
Hi. What is your policy if you see a ligament ossification? It looks like a disc herniation, but it is an ossified mass very ventrally. Which surgery do you prefer? Do you make a thoracotomy or what?
No, I would still do I would do a minimally invasive lateral extracavitary so that I can come in almost parallel to the lateral aspect of or perpendicular to the lateral aspect of the dura. That gives me pretty nice exposure to be able to get in there and drill that off and push it down away from the dura.
Okay. Recently there are some publications coming from Europe, especially from Netherlands, making a transdural surgery for midline calcified disc. What's your comment on that? It is like the people are going backwards. 30 years before, my boss was doing the similar thing. What do you think?
You know, that's interesting. It's relatively safe because you absolutely expose the spinal cord and you can reach underneath it to tap those osteophytes away. The problem is you create a ventral dural defect, and then you have to try and figure out a way to seal that, number 1, to prevent a CSF leak, and number 2, to prevent ventral herniation of your cord into that space. So it comes with significant problems too.
Right. Thank you. Thank you, really. I appreciate it.
Okay, next question, Professor Galgano, Professor Benzel. Do you have any question?
I think Dr. Fessler answered it in regards to using a endoscope for heavily calcified disc. Obviously, we all get CAT scans anytime we're about to take on a thoracic discectomy case. Some of the ones I've done in the last year and a half of my practice have been heavily calcified. What's your experience taking on a heavily calcified disc, or like you said, are you just doing a mini open costotransversectomy or extracavitary for these?
I would do the mini open or minimally invasive lateral extracavitary, and I have to say that's an operation that makes me very nervous because you never know, especially if it's a chronic calcified disc that is impinging upon the dura or maybe has gone transdural. You never know if it's actually going to be adherent to the spinal cord. Many years ago, I did have one that was that way, and I did an open lateral extracavitary. But you know, the disc herniation was so adherent to the spinal cord that removing it paralyzed the patient. So you have to be, you know, that's an operation when it's very calcified that makes me very nervous even to this day.
Yeah, likewise. Do you have any tips as far as interpreting on the MRI scan if you may encounter an intradural disc?
You know, I don't think there's really a way of knowing for sure. And I think, you know, until you get there and you can, you know, make an incision in the lateral aspect of the dura and actually inspect the cord and see if you can pass a Penfield 4 underneath between the cord and the disc fragment, you really can't tell until you get there.
Sure.
Okay, thank you.
So my only comment here from a global perspective is that Dr. Fessler's major emphasis is on trajectory. You have to select the appropriate trajectory to achieve what you need to achieve in the safest manner. And if you're not familiar with the operation that is associated with that trajectory, you shouldn't change the operation to an operation that you are familiar with, like a more laminectomy type approach as opposed to a more ventral approach, you should get the patient to the surgeon who is most appropriate for that type of a case.
I absolutely agree, Ed.
Okay, thank you. Thank you for this comment, Professor Benzel. I think that it has been the last comment. Maybe we can move to the next speaker. But before that, I'd like to thank Professor Fessler and all the other participants in this fruitful discussion for the time and contribution. Professor Fessler, thank you very much in behalf of all the listeners. Okay.
So just real quickly, I have to sign off now, but Naren is going to send me the chat questions. Hello, Naren. He's here. I'll assume he's going to send them to me.
Sorry. I have already sent them to you, Dr. Benzo.
By email?
Email, yeah.
I do not see them.
Okay, I'll recheck and send it again.
Okay, I'll look in my junk mail.
Thanks, thank you.
But I don't see it there either.
Okay, I'll resend it.
Okay, thank you.
Thank you, sir.
Thank you.
You bet.
So it's my pleasure now to introduce Dr. Kara Sedney. Dr. Sedney is the associate professor of neurosurgery, the spine surgery at University of West Virginia. Dr. Sedney, I'll just, she's going to talk about thoracolumbar fractures. Let me just get her. Hi.
Naren, can you let me share my screen?
Sure. Just a second. Great. You should be able to do it now.
Thank you.
Thank you very much. So Dr. Sedney is going to talk about thoracolumbar fractures. Certainly, this is something that all the residents and young neurosurgeons see daily, and a thorough grasp of this will be very useful, not only daily practice as well as for the exam. So Dr. Sedney, look forward to your talk on what's the current practice. Thanks a lot.
Yeah, thanks so much for the opportunity to speak, Naren, and particularly among such a really eminent group of speakers. I'm going to talk about thoracolumbar trauma, and as Naren mentioned, it's probably more relevant for the trainees in the group. My only relevant institutional disclosure is that our orthopedic surgery spine fellowship is supported by the AO. So in order to sort of get across such a broad topic in 15 minutes, I'm going to mainly talk about classification systems. And there are two main classification systems, and they really serve two unique functions. One being to describe or communicate, to give us a shared terminology in order to describe what we're seeing when we're talking to colleagues or supervisors, and then also to decide what to do. And so I would argue that these two classifications are actually complementary, not in competition with one another, and both can be utilized for two different purposes. So the first I'll talk about is the AO thoracolumbar classification system. It's a morphologic classification of the fracture based upon what it looks like. The management decisions are not inherent in the classification. You have to know something about that type of fracture to know what to do. So you can't label the fracture with the AO classification system and automatically know what you have to do to manage it. The classification system is formed by expert consensus, and there are multiple variations. Some are more complex than others. Some include neurologic or clinical modifiers, and the inter and intra-observer reliability varies kind of in general based upon the complexity of the specific version of this classification system. And so when we go over it, I'm going to go over just a really basic version of it. So for the type A fractures, those are going to be your compression type injury fractures. So type A1 is just a wedge compression fracture, in general fairly benign and very ubiquitous. We see them all the time. Type A2 is a split fracture or pincer type fracture, a vertebral body split that's vertical. And something that's important to know about these fractures is because of the fracture morphology, these are a little bit higher incidence of non-union, so late non-union, late pain, and might eventually need surgery. Again, that's not inherent in the actual fracture type. You just have to sort of know that about that specific subtype. And then once we get posterior wall involvement, then we move into the classic burst type fractures. So subtype A3 is an incomplete burst where one end plate is intact and the other one is comminuted or fractured. And then subtype A4 has both end plates involved. And I'll just point out, I hope you can see my mouse, both the A4 and the A3, you can see this little fracture, split fracture of the lamina. Okay, that is part of the description of a burst fracture. That does not confer any increased instability just because of itself, because that is not part of the posterior ligamentous complex. And so my residents will often say this is posterior wall or posterior column injury. It is not. This is still an A3 or an A4 fracture in spite of this split fracture of the lamina. Next is subtype B, and those are going to be tension band disruptions. Type B1 is a transosseous disruption of the tension band. And so that's going to be your classic seatbelt injury or chance fracture. It's important to differentiate these from a compression fracture if they are not distracted as this one is. And then subtype B2 is going to be a ligamentous disruption or an osseous involvement of the posterior ligamentous tension band. And so that one is going to be what you're trying to identify when you're looking at an A3 or an A4, if they have a posterior tension band involvement, that is actually a B2, which is a more serious type of fracture that requires surgery in most cases. And then as you can see, the higher we get in the classification, the more severe the injuries are. This is a C1, a hyperextension injury. This is one that you have to have a high index of suspicion on because sometimes radiology will call these just an end plate fracture, particularly if it's not distracted. But it is actually operating like a hinge. Okay, this anterior tension band is gone. And so those are fairly unstable, particularly in the setting of an ankylosed spine. As you can see, this is with the one vertebral body fused to the other. And then subtype C2 is a translational injury. And so that's disruption in any plane. Okay, and so you can see over here the ends of the spine don't line up. So that's how we know it's a translational injury. And significantly, we need to remember that radial translation, radial spread is also a C2 type of fracture. So we can see the radial spread here, the vertebral body. That's not just a burst fracture. That is a translational injury, more serious injury than a burst fracture would be. And then C3 is a separation injury. Those are generally pretty obvious that those need some kind of operative fixation. And so working through this, how we utilize this in clinical practice, it's generally good to assume that you have something bad in medicine and then convince yourself sequentially that you don't and what you have is actually something safe. And so you want to start assuming that you have something really bad, assume that you have a C-type injury, look for displacement, separation, or translation. If you don't have any of those, you can say, all right, maybe it's not quite so bad. You look for a tension band injury. And there's a couple of different ways to do that. The low-tech way, if you feel it is safe, is to stand the patient up and look for kyphosis. You can also get an MRI and look for actual ligamentous disruption. And then if you decide that those are not what you have, then you look at the morphology of the vertebral body and you decide what kind of A-type fracture you have, and that can help you decide your treatment. So that's the AO classification. TLIX is the other type of classification that's widely used, and it's a little bit different. It's based upon morphology, as well as the integrity of the posterior ligamentous complex and the neurologic status of the patient. It is also, like the AO classification, formed by expert consensus. It guides treatment, which is something that AO does not inherently do in the classification, and it possibly has better inter-observer reliability. And so this is the TLIX scoring system. You can see that it looks at the morphology similar to the AO classification first, and then neurologic involvement using root, cord, or cauda equina involvement. And then the posterior ligamentous complex is determined to be either intact, injured, or indeterminate. And then you add all those up, and that helps you determine what your management strategy is going to be. If they have 0 to 3 points, it's non-operative. 4 points is operative or non-operative, and there's a wide range of fractures that are going to fit into that category. And then greater than 5 is clearly operative. And so if you Google search TLIX, you can actually have a web-based calculator that comes up, and you can put your components in there, and it'll give you a score. If you don't have wide internet access, there's also an app for your smartphone that you can download that does the same thing if you can't remember the different components. And so you can see here that if we had a burst type morphology of the vertebral body in an intact patient, but the posterior ligamentous complex is injured, that's a 5, so that's clearly operative. So the TLIX can help you figure out what to do in terms of whether or not you need to operate. But in terms of what operative approach you take, there's really not a lot of guidance within TLIX. And that's really because there are many, many, many management options. There's wide regional variation in terms of how many fractures are dealt with, and no clear evidence of superiority one way or another. And so it's best to think of treatment of these lesions in terms of basic strategies or basic principles. And so when you're treating a fracture, you want to stabilize, okay? You may want to fuse if they need long-term stabilization, i.e. if you think that the fracture healing itself will not restore stability. And you may want to decompress. Some people will decompress anytime there's compression. Some people only decompress if there is a neurologic deficit. I happen to be one of the latter group. I only decompress if the patient is not neurologically intact so that I can preserve fusion surface. And just to illustrate the wide variation in treatment of different fractures, let's talk about an A4 burst fracture, which would, in a neuro-intact patient, would be a TLIX 4. So that's operative or non-operative. These are all the different things that have been described as treatment for A4 fracture. You can do nothing. You can brace them. You can do an anterior stabilization with or without posterior fixation. You can do an MIS anterior stabilization with or without posterior fixation. You can do posterior long segment stabilization, posterior short segment stabilization. And with that, you can use pedicle screws, Chance pins. You can do MIS techniques. There's really so many variations. And I can tell you that in my hands, in my practice at my institution, if you came in neuro intact with an A4 fracture, I would stand you up to assess the posterior ligamentous complex. And if there was no significant kyphosis or other problems, I would do nothing. However, in other institutions, that person would get a front back fusion. And there's really no definitive evidence to say that one way is better than another. I do know that there are several large studies currently ongoing, however, to determine that. Just to give another resource that's available for people. This is an example of the resource on the AO website. If you want a breakdown of the different treatment options for each fracture type, they will talk about the skill level involved, the equipment involved, and then various contraindications, advantages, and disadvantages for each surgical approach to try to figure out what's the most appropriate. And so if you are in a situation where you're trying to figure out what to do and you don't have a number of colleagues to confer with, this website is also a really good resource. So going back, we'll do a couple of cases. Going back to the first picture I showed, this is a young man who had an all-terrain vehicle accident, obviously neurologically complete. And I think the interesting talking point about this fracture is the reduction strategy. So in general, for fracture reduction, you can often get a lot of reduction when you just put them on the table. If you're using a Jackson frame, a lot of times fractures will reduce. Obviously, that did not work in this case. So another strategy that you can utilize is just to put your screws in. Putting your screws in with that downward force will often help with fracture reduction. If that doesn't work, another thing you can do is remove any soft tissue or bone. In particular, the facets are often something that are going to hold you up. In this person's case, the disc was something that we were concerned was holding us up. You can put clamps on the spinous process and get up over the patient and pull down on one and push up on another. For this particular fracture, we had to actually, the thecal sac was completely transected. And so we actually just removed, did sort of a partial corpectomy of the superior aspect of that vertebral body and then tucked it back in. And he ended up with something like this. afterwards. Then utilizing our classification system, this is two different patients that came in at the same time in a car accident. This was a married couple. So the person on the left was the female, and she had an incomplete caudate equina level injury. This is the male. He had a complete thoracic cord level injury. And so just going through our classification systems, for this patient, she had no separation or translation really. Her tension band, as far as we could tell, was probably indeterminate, but I do believe it was intact. But she did have a complete burst fracture. And so she would be an A4 based upon her TLIC scoring. And so utilizing that, we have our 2 points for our morphology. She's got a caudate equina level injury with an intact posterior ligamentous complex. She's clearly operative, okay? And we actually operated on her first since she was incomplete. And then for him, this was a, there is displacement, but no separation. So this is a translation injury, and you can tell because the two ends of the spine don't completely match up. You can see all the spinous processes here, none here. This is T7, I think, and then this is 6 and 8. And so you can see it was retropulsed back into the canal, which is why he was complete. And so we did her first and then did him second. For her, I greatly favor a posterior approach because it's very serviceable in any hospital with any assistant. And so we did a laminectomy, used footed tamps to tamp down the vertebral body, and then did long segment fixation. But I used hooks as the bottom fixation points to preserve a motion segment for her, and then short screws in the fracture level. And then for him, removed all this from the canal. His cord was actually, the fecal sac at least was completely continuous. So we removed all of this, put a small cage in there to take up some of the space, and then did a long segment fixation since he wasn't gonna lose any motion from that. So in conclusion, I'd just like to quote one of my mentors, who's John France. He's an orthopedist, and he says that you really have to learn how to like trauma, because if you learn to like trauma, you will always love what you do. And I think that is just a really great way to look at trauma. It's always interesting and always different. And if you have fun with it, I think you always have fun with your job. So thanks very much. I'm happy to take any questions.
Thank you very much, Dr. Sidney. This is very useful, and certainly for someone from pediatrics and previously done spine, it's nice to recap. While others are coming up with questions, I just wanted to ask you, did these classification come in the days mainly when it was axial, sagittal, and coronal CT scans, or do you think now that more and more of us have the 3D reconstructions, the classification will change?
So certainly the AO classification has been constantly evolving, and the AO is a very old organization, very old classification. They classify fractures in all bones of the body, really. And so I don't anticipate 3D reconstruction to change the classification system, but I think it does maybe help us in performing a classification, you know what I mean? In order to sort of really assess the fracture morphology. TLIX itself, the fracture morphology is only one part of it, and so I don't anticipate that changing based upon imaging.
Thank you. I've got a question from Dr. Vasabag. I'll just unmute him. Just a second.
Hi, can you hear me?
You want to go ahead, please? Thanks.
Yeah, can you hear me now?
Yep.
Yes.
Yeah, thank you for that great talk. I just wanted to ask you about type C fractures, which are often associated with polytrauma, chest injury. What's your approach to timing of surgery?
For type C injuries?
Yeah.
So they are very generally multi-trauma. I will tell you though that unless they have some kind of acute hemodynamic instability that would require opening the belly or something like that, we generally will do the spine as the most urgent thing for many reasons. It affects their ability to mobilize the patient, and so that affects their pulmonary health. And so our trauma doctors are very behind us being aggressive with that rather than waiting. And so we sort of, the default is to take them for surgery, and I wait for my trauma doctors if they have reservations to tell me no.
Okay, great. Thank you very much.
Thank you. There's a question from Dr. Juan Morales. Dr. Morales, do you want to go ahead?
First of all, thank you for your talk. When you have clicks of 4 points, what do you have to consider in order to operate a patient? I mean,
In which specific instance?
In general, I mean, this score makes you think that you have to operate and not operate a patient, but that 4 points, I'm a resident and I don't know what to consider to operate, to take a decision about to treat that patient. I don't know if it depends of the fracture or what do you have to consider.
Oh, understood. So so I think the TLIX is very helpful in that situation, because in general you're going to, intuitively you think, if the patient has a neurologic deficit, that seems more operative, right? And so that's why neurologic deficit in the TLIX grading system really pushes you up over the operative threshold. And so even if you have a relatively benign looking fracture, if they, even just a compression fracture, which is going to give you 1 point, if they have a neurologic symptom, that's going to almost always push you into the indeterminate area, which makes you consider surgery. You know what I mean? And then certainly the more significant fractures, if they have a neurologic deficit, that's going to push you more towards surgery. And so I think the neurologic status of the patient is very important, and that is inherent in that TLIX scoring system. For the AO classification, it's a little bit harder to discern that. And that's one of the downsides of the AO classification, is that you have to have a lot of background knowledge to know in order to use that. So I think that in answer to your specific question, I think that the TLIX is more useful because it inherently weights those more important things as worth more points to get up to the score that will push you in an operative direction for those operative things. Does that make sense?
Yeah, very sense. Thank you very much.
Thank you. There's a question from Dr. Abi. Dr. Abi, do you want to introduce yourself, full name, and where are you from, and ask the question? It's a general question. Thanks. Dr. Abi. And I will ask further question for Dr. Abi. He or she was asking me, what's your general principles for dural tear when managing fractures? Kara?
Good question. So I think in you do the best you can. You know what I mean? You sew it up. I like to use interrupted neurons, but you do the best you can. And I think you have to assume that you're going to get those specifically for those split fractures in the posterior elements. Those will often trap the dura in them. And so you have to sort of assume that you're going to have one and need to fix it. But you really do the best you can. So for anterior dural tears in some of those burst fractures, it can be very tricky. And sometimes you can't get it perfect. I think that getting the patient off the table and balancing that with controlling the CSF leak are really important. And I don't know that I have any other tricks other than that, though. Sorry.
Thank you. Dr. Seni, there are 3 or 4 more questions for you there, but for the reasons of time, if I may please ask you to reply them on the chat box, I'll be grateful.
Of course.
Thank you very much for your lecture, and thank you very much, Professor Miguel Ares. Thank you for your support.
Pleasure.
Session, as well as for all the projects and previous INRC excellent INRC in Malaga, and also for the WFNS Foundation. It really has been with Komal and you have been one of those people to have with to make projects. So what's the time now? In 55 minutes, we will go to the 4th and final session. So at the end of the final session, I will give you the link for you to fill the feedback form and for the certificates. We have another excellent session. We have got spinal cord tumors from Dr. Jallo. We have got Dr. Patkar talking about lumbar radiculopathy, and then the ever troublesome discitis and epidural empyema, Dr. Shari Q from West Virginia as well. and then Dr. Ritter from Penn State, taking us through the controversies of cervical spine trauma. So it's another excellent session, and you can get yourself some rest and for the next 15 minutes, and I'll see you again. Thank you very much again.
Thank you, Naren. Great.
Yes.
Congratulations.
Thank you.
Thanks, Naren. Lovely session.
Great.
Thank you. I'll leave the computer on as before, and so that this is the same room, and also Dr. Sedney can answer all the questions. Thanks.
Hello.
నాకు నీకు ఒక 5 నిమిషాలు కూడా కాలే. ఇది కిందకి వచ్చింది.
ఏంటంటే
సైలెంట్ ఉండరా.
నువ్వు అది ఒట్టిగానే తీసు ఒట్టిగా తీస్తే చూడు చూస్తా చూస్తా
దీన్ని ఎట్లా డిలీట్ చేయాలబ్బా? ఇది ఇన్లెక్కింది, కిడ్నీలకు పోయిందబ్బా. ఇది అవులది వాయిస్ దీన్ని ఎలా తీయాలి?
వాయిస్ వచ్చేది
ఏంది ఇది? మన వాయిస్ గిన్నె పోతుంది. సైలెంట్ ఉండరా.
రాజేష్ గారు ఎక్కడి నుంచి సార్ మీరు?
ఇంకొకటి చెప్పాలి. నా నోరు కడుపుతాను ఏంటంటే నీ ఫోన్ పాడు చేసింది. నేను మాట్లాడింది నేనే. నీ ఫోన్ ని పాడు చేసింది నేనే.
వామ్మో ఏందబ్బా ఇది
ఏమనుకున్నావు ఎలా
ఇట్లా వెళ్తుందబ్బా సెల్లకి ఇది
రికార్డింగ్ పెట్టినాం కావచ్చు చూసుకో నాన్న పెట్టలే నేనే పెట్టి నన్ను ఎక్కదాడి చేస్తే ఇలాగే ఉంటుంది మనం మనం
నేను ఒక గంట పని చేసిన
నువ్వు రికార్డింగ్ పెట్టినావేమో రికార్డ్ అవుతుందేమో
రికార్డింగ్ పెట్టినా కానీ వాయిస్ పెట్టలేదు అన్ని రికార్డ్ అయినా వాయిస్ రావట్లేదు
వాయిస్ ఎందుకు రావట్లేదు మరి
నేను వాయిస్ తెలియకుండా ఆఫ్ చేసిన
సైలెంట్ లో పెడతావు కదండి
అదే నాకు తెలియదు నా ఆపరేషన్ నాకు తెలుసా ఇది వేరే దగ్గర నుంచి తీసుకున్నా
ఏంటంటే ఈ ఫోన్ ఉంది కదా, మనం ఫోన్ నుంచి అన్ని కదా కట్ చేస్తాం. మనం మాట్లాడేదంతా డైరెక్ట్ టీవీలోకి వెళ్ళిపోతే అప్పుడు ఏం చేస్తామమ్మా? అందరూ ఇలాంటి టీవీ తీసుకున్న వాళ్ళు చూస్తే మనం నవ్వుకుంటారు. అందుకే వెంటనే ఫోన్ ని పలగొట్టే, అట్లయితే మొత్తం పని అయిపోతుంది. పారేడు కాదు,
ఇక్కడ ఏదన్నా పలగొట్టేయాలట.
లేకపోతే ఇక్కడ నాటం అది కూడా టీవీలోకి వెళ్ళిపోతుంది. చూడడం ఆపై వెళ్ళిపోతుంది టీవీలోకి. ఇందాక నీ సెల్ కూడా కరెక్ట్ అయ్యేది అట్లా ఆటోమేటిక్ గా
మైట్ బై ఉండొచ్చు.
ఏం చేయలేదు.
వెబినార్స్ అనేది నాకు తెలుస్తుంది ఎంతమంది. వెబినార్స్ గురించి ఐడియా లేదు.
చూడు బాంబా
ఏంటది? బామో బామో
నా చెయ్యి దీని లోపల ఇప్పుడు
రాజేష్ గారు